Thank you so much, sir. Thank you so much, everyone. The National Workshop on Preventing Antimicrobial Resistance Together is Speak Live has inaugurated. Now I invite Mr. Satya Shivaraman, Communication Coordinator, React Asia Pacific, to speak a few words. Mr. Satya Shivaraman will be interacting with us in an online mode. Is unavailable at the moment. We shall move on. Now I invite Dr. K. Brinda Menon, Officer in Charge, School of Zoonosis, Pathobiology and Public Health, for the vote of thanks.
Respected dignitaries on the dais and off the dais, we are extremely happy to organize this workshop on antimicrobial resistance for the 2 consecutive years. And the School of Zoonosis, Public Health and Pathobiology is very happy to collaborate with REACT and the Veterinary Public Health Department for the same. Moving to my duty to express my word of thanks, we are extremely thankful and grateful to IR Sir for accepting our invitation in spite of his ill health to inaugurate and grace the occasion. On the behalf of the organizers and on my personal behalf and everybody gathered here, I thank you, sir, for coming over here to inaugurate the function and grace the occasion. Next, I would like to thank all our resource persons who have accepted our invitation and who have joined us online as well as offline for the technical sessions on AMR. And I hope that we'll have a fruitful deliberations in both our discussions in the forenoon and the afternoon sessions. So thank you all for accepting our invitation and coming over to the function. The program would not have materialized without the financial support of REACT Asia Pacific. We are very grateful to REACT Asia Pacific for supporting us for 2 consecutive years to conduct the workshop on AMR. Our special thanks to Mr. Satya Shivaraman, Dr. Jaya and Mr. Thomas Matthew of REACT Asia Pacific, who have coordinated in all our activities as part of this program. I would also like to thank our other sponsors, Chemin Chemicals Thrissur and Origin Chemicals Column, for the financial support. Next, I would like to thank all the delegates who have joined us offline and online for the workshop. Our special thanks to Dr. Sunil B., Head of the Department of Veterinary Public Health, for his guidance and wholehearted support for the program. Last but not the least, I would like to thank all the faculty members of the Department of Veterinary Public Health and other faculties who have joined us for this program, and the PG students of our department and supporting staff of Department of VPH for the help rendered for the conduct of the program. I hope we'll have a very fruitful deliberations on a very upcoming it's a topic which have been in news for the last so many decades, antimicrobial resistance, and come up with certain recommendations which could be implemented in the near future. Thank you all once again.
Thank you so much, ma'am. We will begin the technical session shortly. In this very special occasion, we would like to honor our esteemed guest, Dr. R.P. Iyer, retired Professor and Head, Department of Veterinary Public Health, College of Veterinary and Animal Sciences, Manudi. Dr. R.P. Iyer stands as a distinguished individual adorned with a profound wealth of knowledge and extensive experience in teaching. He has served as the first head of the Department of Veterinary Public Health Department. To honor his valuable services and contributions, we take this opportunity to bestow Dr. R.P. Iyer with a token of appreciation. I request the presence of Dr. V. Sunil, Head of the Department of Veterinary Public Health, on the dais to honor our guest. With much respect, I invite Dr. R.P. Iyer to receive our token of love and appreciation.
Good morning, everybody.
Good morning.
I am a replacement for the collector of this district. So this came as a sudden, unexpected gesture on the part of the organizers. The subject, awareness for resistance to microbes, is more than centuries old. The early 20th century, this came up as an important matter during the First World War. WHO recognized the importance of it after the Second World War, and then decided that there is a multivarious activity has to be done to resistant bacteria. I'll come to how the resistant bacteria comes up earlier. It is mainly a man-made problem. Under treatment, without prescription, pharmacy people issuing antibiotics of any nature, and then the exact diagnosis and treatment is not taken up in every case. Normally any fever antibiotic is good. This is not shown whether it is done in a proper way or not. What I want to say is this very man-made. Just like the terrorists that we have got now. This is a terrorist organization. They develop very fast the field and the nature. And even man is also susceptible to this. I will give you an example. Now how this can happen is a different way. By adulteration. When I was a student, of course, we went for a drug inspection laboratory in Calcutta. Casually asked them, have you come across anything interesting? Because they were all routine monobulk. He told us one instance. We usually collect samples of the field regularly and test it for its genetics. But once we came across in one particular drug formulation, antibiotic named formulation, aspirin only. The doctor prescribes it, temperature comes down, after some time again the temperature comes down, shoots up. Because it requires typical antibiotic, not adulterated antibiotic. So this particular awareness program is not restricted to Only each one instance, it can happen in many ways. Adulteration can also induce a certain amount of mismanagement of diseases. This was started by them as a program of awareness, because mass awareness is important to curtail this menace of disorder. The World Health Organization decided to have March, November 22nd to 24th as the World Awareness Day for this antibacterial menace. That I think that this is a part of that work. That's how this is being organized. People are not much aware of it. I can go to a dispensary, a medical shop, and purchase medicine, antibiotic, anything I want. And once my temperature comes down, I stop it. That is responsible enough for that one. There are even some suspicion that the enteropathogenic E. coli, that's a harmful effect, particularly in pigs. It produces edema, infection, treatment, fever, and death. It is considered to be one of the absolutes of this particular phenomenon. I don't want to go on telling because my memory is losing very fast. I have now completed 28 years as a lecturer. So you can imagine what will be the nature of my knowledge or the current knowledge that goes along with this one. Please excuse me for that one. I wish the organization well, and I officially inaugurate this workshop on this issue. Thank you very much.
Thank you so much, sir, for your enlightening words. Let us begin the technical session. The session will consist of 7 speakers. Each talk is for 20 minutes with 5 minutes of discussion after the end of each talk. The organizing committee would like to introduce the chairman of today's technical session, Dr. Thrissur P. Dr. P. Thrissur serves as the professor and head of veterinary epidemiology and preventive medicine at the College of Veterinary and Animal Sciences, Manipur. With an impressive 29 years of experience in teaching, she has demonstrated a steadfast dedication to ongoing education and has engaged in numerous international and national training programs, along with active participation in more than 65 seminars. She has mentored 55 PG and PhD projects. Her scholarly impact extends to 165 published papers and 180 presentations at national and international forums. Recognized for excellence, Dr. Thrissur has received prestigious awards such as Best Teacher Award, Best Veterinarian Award, Best Paper Award, and Gold Medal Awards from the ISVM. With an illustrious career, Dr. Thrissur embodies the epitome of expertise and dedication in the realm of veterinary science. We welcome you, Dr. Thrissur PV, the chairman of today's technical session. The session will be co-chaired by Dr. Sushila KV, Professor, Department of Microbiology, Amala Institute of Medical Sciences, Thrissur. With an impressive 3 decades of experience as a consultant microbiologist, Dr. Sushila KV is an accomplished professional with a portfolio encompassing over 20 research publications. Noteworthy contributions include published case reports on Neisseria cholerae, Campylobacter, and non-tuberculous mycobacteria infections. Her expertise extends to being an invited speaker at the 5th World Congress on Infectious Diseases held in Boston in October 2023. Focused primarily on bacteriology, her extensive career reflects a commitment to advancing knowledge and addressing critical issues in the field of microbiology. We welcome you, Dr. Sushila Devi, to co-chair today's technical session. We now invite the reporter for today's session, Dr. Ampli R, Assistant Professor, Department of Veterinary Microbiology, CDS Manuri. Dr. Ampli R, currently an Assistant Professor in the Department of Veterinary Microbiology, holds a BDSc MH and achieved first rank in MBSc in Veterinary Microbiology from the same institute. She completed her PhD in Veterinary Microbiology in 2012 with an Inspire Fellowship. After working as a veterinary surgeon for 2 years in AHD Kerala, she transitioned to academia, joining as an assistant professor. Dr. Ampli has served as a principal investigator in various projects and currently she leads an ICMR-EMR project on the molecular characterization, antibiogram and geospatial analysis of leptospiral isolates from Kerala. Additionally, she serves as a co-principal investigator for projects funded by NABARD and KSST. Her impactful research is evident in 40 publications in peer-reviewed journals and has mentored numerous students in both major and minor advisory roles. Her commitment to both teaching and research highlights a distinguished academic career. Welcome Dr. Ampli to the technical session. The first speaker for today's technical session is Dr. Deepthi Vijay. Dr. Deepthi Vijay, an accomplished professional in veterinary public health, holds a Doctor of Philosophy from Guru Angad Dev Veterinary and Animal Sciences University in Ludhiana, MSc from the Royal Veterinary College in London and a postgraduate diploma in One Health from Kerala Veterinary and Animal Sciences University. Presently, she serves as an assistant professor in the Department of Veterinary Public Health at the College of Veterinary and Animal Sciences, Manuri. Her academic achievements include being a certified professional in biorisk management by the International Federation of Biosafety Public Associations and a member of significant professional bodies such as the British Society for Antimicrobial Chemotherapy and the Indian Association of Veterinary Public Health Specialists. She has received numerous awards and recognitions, including the Grassroots Science Award Advice Promotion Awards 2023 by INGSA Asia, the Best PhD Thesis Award, and the DST Augmenting Writing Skills for Articulating Research Award. Her magazine articles, her academic contributions are extensive with 15 origin research articles, 16 awareness magazine articles, commentaries and book chapters. Dr. Vijay has also co-authored a textbook on zoonosis published in 2022. Dr. Deepthi Vijay is also involved in the ISOHA mentorship program and guides MSc and MBSc students. Her dedication to research, education and mentorship exemplifies her commitment to advancing in the field of veterinary public health. I invite Dr. Deepthi Vijay to handle our first technical session on the topic Antimicrobial Resistance and One Health.
Very good morning to one and all present over here and who are joined online. Warm welcome to my presentation on antimicrobial resistance and body health. Let me start with an overview. Let me start with how AMR develops. Just an overview. We know that there are bacteria all over the earth. Earth composes of around 5 into 10 raised to 30, around 5 million trillion bacteria, and of which human body composed of around 40 trillion bacteria. That is, it outnumbers the number of cells in human body. Human body composes of around 30 trillion cells, and number of bacteria in human body is around 40 trillion. And we know that there are good bacteria and bad bacteria. In simple terms, bacteria can cause infection, and we have got antibiotics, which are the magical discovery of modern medicine, which are given to kill the bacteria, and of which some bacteria may resist the antibiotic treatment and they continue to multiply by various mechanisms. In nutshell about various mechanisms, there can be various mechanisms which are developed by the bacteria, like they may have various drug effects, pumps might be there, various enzymatic breakdown of antibiotics will be there by the bacteria, or even the bacteria can modify the antibiotic target. So through these various mechanisms, bacteria try to overcome the antibiotics administered against them. And those bacteria which gain a selective advantage moves on these antimicrobial resistant genes through various mechanisms of horizontal gene transfer to other bacteria, and it will ultimately result in a colony of resistant microorganisms. Actually, antimicrobial resistance is a natural phenomenon of the bacteria, that is a part of the evolutionary and ecological process of microorganisms as a result of their adaptation to the environmental selective pressure. Environmental selective pressure is a part where humans and animals and the environmental sector has to the selective pressure to the emergence and spread, that is antibiotic use as well as misuse, has significantly accelerated this evolutionary process of microorganisms. Let me explain antimicrobial resistance severity. Antimicrobial resistance has been projected as one of the greatest global public health challenges by the World Health Organization. And according to 2019 report, global deaths per year, around 1.2 million deaths were attributed to antimicrobial resistant infection in 2019, which outnumbered the deaths due to other causes such as HIV, breast cancer, malaria, and these superbugs are a greater threat, even a bigger risk than that of cancer. And if this trend continues, an extra 10 million deaths are projected due to AMR by 2050. And all of this attributable deaths due to antimicrobial resistance are mostly concentrated in 3 regions of the world: South Asia, Sub-Saharan Africa, and low and middle income countries of Southeast Asia. These are the regions which are attributed as a hotspots of antimicrobial resistance. As told, 1.3 million deaths are attributed to AMR every year, One child dies every 3 minutes from a multi-drug resistant organism sepsis. And if the trend continues, we will have around 28 million people still living in poverty by 2050, which creates an additional healthcare cost of around $1 trillion by 2050, and by 2050 we will have around 7.5% decline in the total livestock population. Let me show you the other side of coin. We have antibiotics and we have a dwindling pipeline of drug discovery. That means there is no new class of antibiotics which has discovered or which has come to the market since 1987. Though latest generation of the old classes such as latest drugs like latest generation of quinolones etc. have come to market, but no new drug classes are approved in the market since 1987. So we have looming antimicrobial resistance of the pathogens, and on the other hand we have no new drugs in our arsenal. So refilling antibiotic pipeline is one of the most pressing needs, which is $1 billion business. Let me quote the quote of Sir Dr. Alexander Fleming, who revolutionized modern medicine by his first discovery of penicillin. In his Nobel Prize lecture, he had a visionary talk that he has told that the time may come when penicillin can be bought by anyone in shops. Then there is danger that the ignorant man may easily underdose himself and by exposing his microbes to non-lethal quantities of drug make them resistant. This was his Nobel Prize lecture talk in 1945. So let me show you the timeline of antimicrobial resistance. Penicillin came into market in 1940s, and as soon as a drug came up, we had penicillin-resistant staphylococcus discovered in 1940s itself. So nearly as quickly as the life-saving antibiotics are created, new drug-resistant infections also appear. So the world is now running out of antibiotics in this situation, and WHO has confirmed it, and it has turned antimicrobial resistance as a global health emergency. Let me show you the drug resistant index pattern of the world. Drug resistant index values, that means poorer efficacy of antibiotics, are concentrated in many countries, particularly low and middle income countries, and we can see in the graph that India is highlighted in deep blue. India is projected as the antibiotic capital, which has the highest consumption of antibiotics as well as the highest rate of antimicrobial resistance among the low and middle income countries according to 2019 report. However, still data is missing from many resource limited regions, and we know that in our closely linked world, a resistance anywhere can be a resistance everywhere. So this varying effectiveness poses a serious threat to global public health, with resistant pathogens easily transmitted between the nations within a span of very little time. Further, added 5% increase was reported, and this increase in global consumption is driven by low and middle income countries, and particularly there was an increase in antibiotics such as cephalosporin, quinolones and macrolide. I must underline the fact that these three antibiotics, cephalosporins, quinolones and macrolides, have been declared by WHO as the highest priority critically important antimicrobials for human medicine. So there was huge increase in consumption of these critically important antibiotics. And to the other side of the coin, still access is an issue in low and middle income countries. That is, in low and middle income countries, still the burden of infectious diseases is greater than the burden of resistant infection. So rising resistance to the affordable first line of treatment still increases the barrier to access in these countries. Let me show you two graphs. First one is the excess antibiotic use, and the second one, the graph beneath, shows the access related mortality in young children. The countries highlighted in various shades of red shows that still access related deaths are happening in these countries, though there is a surging antibiotic consumption. Antimicrobial resistance is actually a complex system. AMR is a natural evolutionary process of the bacteria, but as the infectious diseases increases, It results in a vicious cycle of decreasing socio-economic growth of the country, which in turn increases the self-medication, over-the-counter availability of drugs, and thereby increases the antibiotic consumption. And more antibiotic consumption lead to more and more emergence of resistant strains, and which in turn perpetuate the burden of infectious diseases. This is happening in a vicious cycle, and it is a complex system to address. Though there is a blame game between various sectors, which sector contributes much to the rise of antimicrobial resistance? This is an evidence-based study published in Lancet in 2022. It is evident that the huge two bubbles you can see in the graph, that is human and animal antimicrobial misuse and overuse, equally contribute to the development of antimicrobial resistance. Apart from that, poor access to quality medicines, vaccines, reliable diagnostic tests, poor infection prevention and control practices, lack of clean water and sanitation, lack of antibiotic agriculture practices, globalization, trade, and poor public awareness. These were the main factors which are listed as the major factors contributing to antimicrobial resistance. Coming to the animal husbandry sector. It is evident that there is 2/3 or 70% of the antibiotics which are sold worldwide are used in agriculture, particularly in intensive farming such as poultry and piggeries. As and when the GDP of a country increases, its purchasing power increases, and more demand for animal protein arises, which lead to more and more intensive livestock production, and thereby it results in increasing antibiotic usage. But do we have any proper surveillance mechanism? Still there is missing data on the amount of antibiotic usage which is administered in animal husbandry sector. And as a result, we have a resistance increase nearly threefold in food animals between 2000 and 2018. Various sectors such as chicken, pig, cattle all have contributed to increase in antimicrobial resistance. There have been threefold resistance in various foodborne pathogens arising from these animals. Let me show you a glimpse of the situation analysis of antimicrobial usage and resistance in dairy sector. We were able to conduct a knowledge aptitude practice survey among various veterinarians to assess the various risk factors relating to antimicrobial usage and treatment failure in dairy herds of India. Around 466 veterinarians participated, and of which the main risk factors projected by the veterinarians for contributing to antimicrobial resistance were widely prevalent quackery in the sector, self-treatment by the farmers, over-the-counter availability of drugs, low veterinarian per animal ratio, limited diagnosis, less focus on preventive approaches, and high prevalence of management-oriented conditions were underlined by the veterinarians who have participated in the survey. So our focus is in there is high prevalence of still preventable or management-oriented conditions in the dairy sector, and there is less focus on preventive aspects or against these infectious diseases. Coming to the animal husbandry and environmental interface. Around 75 to 90% of the antibiotics which are administered to animals enter the environment in an unmetabolized form. That is around 55 to 85% of the tetracyclines, oxytetracyclines, endotoxins, all of these are emitted by the animal in the feces in an unmetabolized form. And around 70 to 80% of the antibiotics which are given to fish are excreted in water as such. The agricultural practices such as application of manure introduce these antibiotic residues and antibiotic resistant bacteria to the environment, and it reaches the humans through contaminated crops, food, as well as direct contact with this environment or animals. To highlight the environmental impact of these antibiotics and antibiotic residues, experts are expecting a 65% increase in drug concentration in water by 2050, and in coming to the situation of world's river, around 2/3 of the world's river have antibiotics among them. And coming to the situation in India, there are reports from India that there are concentration of antibiotics found in wastewater were higher than the concentration you find in the blood of a patient who is undergoing treatment with antibiotics. So this is, and even the developed world is no much different. Even the Europe's largest rivers are polluted with various type of antibiotics, and by 2050, and nearly 2/3 increase will be there in the leakage of antibiotics to Europe waterways. So this is a situation from developing as well as developed nations. Now, let me stress on the environmental factor. Apart from the antibiotics, there are various components such as biocides, herbicides, or chemicals, metals, etc., and various pharmaceuticals which contribute to the selection pressure. Apart from antibiotics, all of these chemicals lead to increasing selection pressure in the bacteria, and there is evidence that heavy metal driven co-selection of antimicrobial resistance is happening in soil and water bodies, which is impacted by aquaculture and agriculture. Metals such as mercury, cadmium, copper, zinc, these were found to trigger the co-selection of antibiotic resistance. Now, another concept is co-resistance and cross-resistance. Let me draw your attention to a case study. That's chloramphenicol is a drug which was banned in Europe since 25 years. But still we have chloramphenicol resistance in the E. coli population isolated from Europe. Why? So there comes the phenomenon of co-resistance and cross-resistance. That is, though chloramphenicol was discontinued, we have a drug known as fluorphenicol, which is widely used in human sector. There is cross-resistance to fluorphenicol, accelerate resistance against chloramphenicol. And another phenomenon is co-resistance against commonly used antibiotics such as aminoglycosides, tetracyclines, etc. will perpetuate the resistance against chloramphenicol because they are located on the same mobile genetic element or same mobile genetic element of the bacteria. So this has led to even antibiotic is withdrawn for 25 years in Europe. Still we have chloramphenicol resistant bacteria in the E. coli population of Europe. Now, another case study is of carbapenem resistance. As we know, carbapenem is a drug which is critical for treatment of gram-negative infections in human medicine, and there is no registered use of carbapenem in veterinary sector. But still, now animals are the reservoir of carbapenem resistant bacteria. We don't have any use of registered use of carbapenems in veterinary sector. It is limited to serious gram-negative bacterial infection, but still animals are reservoirs of carbapenem resistant bacteria. And now, so there comes the role of One Health. Now, another report to grab our attention is that is there any link between spread of AMR and global pollution? This is a report which came in Lancet in 2023 August. There is a significant correlation between the increase in PM particulate matter 2.5 and antimicrobial resistance. So it is estimated that if the pollution continues as such, in 2018 there was an estimated 0.48 million premature deaths and 18.2 million years of life were lost in 2018 due to PM 2.5, particulate matter 2.5. WHO has recommended that only if we reduce particulate matter content to 2.5 to 5 microgram per meter cube, we will be able to reduce this antimicrobial resistance deaths by at least 20%. So particulate matter 2.5 limit is set as 5 microgram per meter cube. But the particulate matter 2.5 concentration in Thrissur today is around 55 microgram per meter cube. So this is a link of global pollution and AMR. So there comes the role of One Health. A One Health approach is needed for AMR. It's human, animal, livestock and environment. All of this equally contribute to all of these sectors equally contribute and are affected by antimicrobial resistance. There is spread of antimicrobial resistant bacteria and genes across this sector. A resistance anywhere can be a resistance everywhere. So there is a perpetuation or there is a cycling of these resistant genes and residues across this sector. So need of research. Let me show you the number of papers on AMR and One Health in PubMed since 1994. There was a huge gap since 1994. The research focused on AMR underlying its One Health perspective started coming up only by 2013, and now it is you can see the data of 2023. So much analogies have been drawn between AMR and climate change, both of which are rightly described as a global tragedy of commons affecting the common people. But the paradox is that there is new drug development is not easy, and new drugs, even if developed, they don't reach the population that need them. Still, access is a problem. So, I have described AMR as a global tragedy of commons. You can see the map that the areas highlighted in red in 3 of the graphs show increased severity of aggregate AMR resistant, antimicrobial resistant, increased severity of corruption, and increased severity of infrastructure. So there is a policy level, apart from intricate linking of all different sectors, there is a need of governance and policy change required, because antimicrobial resistance is concentrated in those areas with increased corruption and lack of infrastructure, and particularly in the low and middle income countries. So it is rightly termed as an invisible pandemic. We have limited awareness still, even though we have global and national action plan by our quadruped organizations, still we have the diagnostic challenge, treatment ambiguities are there, there is low or limited lab capacity, concept complexity is there, and variable resistance, and there is lack of imperative or effective communication is not there, there is limited awareness. To conclude, antimicrobial resistance is a complex to understand as well as it is complex to act. Factors other than antimicrobial usage as important. I have pointed out in the first slide that antimicrobial resistance is just an evolutionary mechanism of bacteria which involve much fitness cost in the bacteria. Living antimicrobial resistant genes will make the bacteria to flourish in a better way. But because of this antimicrobial resistance selection pressure, they need a selective advantage of having these antimicrobial resistant genes. So apart from antibiotic usage, various factors such as water, sanitation, agriculture, animals, environment, along with that governance, corruption, limited education, income, competency, rule of law, health expenditure, all of this complicate the antimicrobial resistance. So what's the solution and what's the way forward? We cannot eliminate AMR, but we can invest in a sustainable pharmaceutical manufacturing. Development of drugs is a billion-dollar business, but there should be sustainable pharma manufacturing. We should focus on infection prevention and control both in human sector as well as in animal sector, with the focus on livestock biosecurity. Access should be there to clean drinking and water and sanitation, which can thereby reduce the burden of infectious diseases. Then another aspect to note is sewage collection and treatment. As told, sewage is a much source of antibiotic residues, and through the sewage these residues are reaching our crops and food sources. So sewage should be collected and should be properly treated, and we should focus on various alternatives to antimicrobials. That is the area which need to be worked upon. So, antimicrobial resistance is a silent pandemic challenging the very foundation of modern medicine. The clock is ticking, and decisive global action is our only prescription for a resilient future. Thank you.
Thank you, Dr. Deepthi, for your wonderful presentation on the emergence of how mechanism of emergence of AMR and the One Health approach to be needed for these things. And if anybody is having any questions, can ask. Okay.
You are mentioning about the pharmaceutical resistance. You might have stopped the production of, or human beings have stopped the production of chloroquine. But the microbes that are producing chlorothiazole, they never stop production of chlorothiazole. So, do you really think that antibiotic usage is the real reason for development of antibiotic resistance?
No.
As you are rightly pointed out, it's an evolution process.
Antimicrobial resistance is an evolutionary process. That means even from pristine environment, even from Arctic permafrost where there was no antibiotic use, we have got antimicrobial resistant bacteria. But the fitness cost of these genes for the bacteria is huge. That is, bacteria has to pay much to accommodate these antimicrobial resistant genes. If the use is withdrawn, withdrawn, if the antibiotic use is withdrawn, there are reported evidence that the bacteria will eliminate the plasmid and it will.
It will not eliminate the plasmid. Have you heard of the concept of pangenome?
Yes, sir. It is persisting in the environment, but the colonies will try to evade this resistant mechanism because fitness cost is huge as compared to the development of resistance. So if the antibiotic use is withdrawn, there are reports that the bacteria will change to sensitive. Though these genes will persist in the pangenome, but they will revert back to sensitive because they by losing this antimicrobial resistance genes, they can invest much on their virulence or much on their flourishment of their growth. So they will eliminate, or what you say, we can shed this plasmid. They will be in the environment, they will exist in the environment, but bacterial colonies will revert back to sensitive.
They are not existing in the environment. They are existing in bacteria itself. That is the concept
But
of
it won't be expressed.
They share when they require.
Yes, sir. When required. That
Say,
is
if you take the case of E. coli, one E. coli will contain maybe less than 5,000 genes.
yes.
If you take a E. coli colony, it will contain 50,000
That's a
genes.
pangenome.
So that is how they share.
Yes, sir.
And by the process of processing and the acquisition of plasmid, the horizontal transfer, the resistance will be there.
But it won't be expressed.
It won't express. Actually, the resistance is reported even before the human has evolved.
Yes. Yes, sir.
Actually, the mistake that we commit when we talk about the antimicrobial resistance is that we always think that these mechanisms are evolved in the bacteria because of antibiotic. It is not, as you are rightly pointed out, these against the environmental chemicals.
Environmental chemical, this biocides,
Because
heavy
the
metals.
earth was so rash in environment before the humans were evolved.
Yes, sir.
All the resistance mechanisms are evolved before that. Means there are resistant factors in the bacteria for the antibiotics which even we didn't discover.
Yes. But it will express, or the expression of these genes are
Will be
perpetuated
more,
by the selection pressure.
number of plasmids in a colony will be more in presence of an antibiotic.
An antibiotic. That is the selection pressure. And I must underline that selection pressure is not only due to antibiotic, it is due to various biocides, chemicals, heavy metals. All of these are
Exactly.
perpetuating the
It is not the
selection
antibiotic that is responsible for antibiotic
pressure.
resistance.
That's irony.
In 1972, chloroquine for resistance was reported in Salmonella, and it was withdrawn. But since 10 or 20 years, it is again susceptible.
Yes.
But you are right, the selection pressure is withdrawn, so
It can become sensitive, but it will be in the bacteria.
Yeah.
As and when it is reduced increases, it will result in expression of such genes.
Again, there will be lots of resistance.
Relapse of resistance.
And what about carbapenem? You told that there is no registered cases of carbapenem use.
Carbapenem is not registered much in veterinary practice, but still animals are now the preservers of these carbapenem resistant microorganisms now.
So that it is used.
Because I just wanted to link the One Health lineage. Though carbapenem is widely used in human sector, but animals in which there is much limited use of carbapenems are the reservoirs of these resistant bacteria.
Okay, it was very excellent. Thank you.
Can you clarify that link between that particular matter, more amount of particular matter and antimicrobial resistance?
Yes. It's a latest report which came in August 2023. As and when global pollution is increasing, the airborne bacteria or antimicrobial resistant genes which are present in the airborne bacteria has resulted in this much. Till now there was linked that there are bacteria in air. There can be antimicrobial resistance in this airborne bacteria. But it has been documented. This is a study, around 116 countries participated, and the particulate matter bacteria containing particulate matter was isolated and the resistant genes were studied. So it was found that there was strong correlation between as the particulate matter 2.5 increases or as the bacterial number increases in such pollution, there was more and more antimicrobial resistance genes, and it was documented that there were around 0.48 million premature deaths due to this bacteria contained in particulate matter in 2018. 0.48 million premature deaths. Airborne bacteria contained in particulate matter 2.5. So WHO has recommended that if it need to prevent antimicrobial resistance, at least to reduce antimicrobial resistance by 2050. We must reduce particulate matter 2.5 to around 5 microgram per meter cube. Thrissur is around 55. We are in good air quality, but that means it's impossible. Thank you.
Okay, thank you, Diti.
Thank you so much, ma'am, for the informative insights on the topic. We now invite Dr. Ragini Ranganathan, Lead Programs, React Asia Pacific, to conduct the next session. Dr. Ragini Ranganathan is a medical doctor trained in social and preventive medicine with expertise on disease surveillance, routine immunization, tuberculosis case finding, and community engagement for TB. She is passionate about designing person-centered, gender-responsive services for the people seeking care. Dr. Ranganathan is interested in employing principles of evidence-based medicine to build the capacity of health workers and demedicalizing health and disease for communities to heighten community-driven demand for quality health services. As lead programs, Dr. Ranganathan is working on the community advocacy platform at React Asia Pacific. We invite Dr. Ragini Ranganathan to handle the session on the topic, mobilizing varied stakeholders for antimicrobial resistance, React's experiences.
Hi everyone, good morning. Am I audible? Hello?
Yes, you are audible.
Okay, thank you ma'am, thank you. Hi, good morning everyone, and thank you for, it's a pleasure to host this workshop with COVAS, and I congratulate the organizing team and all the speakers for having observing World Antimicrobial Awareness Week in this fashion. Mine is not a strictly educational session. We were invited to talk about React, and Dr. Deepti just very well, in a very comprehensive fashion, she spoke about AMR and One Health. So I'm merely here to share about what React does, and I'll not take much of your time. As a continuation to what Dr. Deepti spoke about, we work with different stakeholders to mitigate AMR. We work on multiple areas. One is, like Dr. Deepti said, sustainable access is a problem as much as antibiotic excess is a problem. Access is a bigger problem. We also always highlight that sustainable access is also important. We believe that antibiotic effectiveness is an essential public good. Just like clean air or clean water, antibiotic effectiveness is something that we should conserve and strive to maintain. And we work towards context-specific solutions. We're very well aware that what works in the West does not work in the low and middle income countries. And we work towards an ecosystem approach. What we are also very conscious about is often we term this fight against microbes or battle against bacteria when we speak about AMR. But it is not really a battle against bacteria. We are all well aware that we should also educate the public that many bacteria are really good for us. And it's only the antibiotic resistant bacteria that we may have to weed out. And we are independent in the pharmaceutical industry. We are a global network spread over different continents, and our React Asia Pacific is hosted at Bangalore, in CSC Bangalore. What we do is we are a civil society voice to influence policy both at the global and national and regional levels, and we encourage action like national policy making, and we also undertake trainings for different stakeholder groups. There is a toolbox that many of you may be aware of. This is called React Toolbox. It gives a very comprehensive overview of AMR and how to tackle it. You could please Google React Toolbox to access the toolbox. It's free of cost, and especially PG students will find it very useful. We also take up AMR by antibiotic resistance by engaging key organizations. We do evidence-based advocacy. Also, we convene and organize multiple meetings and action against AMR. In particular, the Act Asia Pacific engages youth through the ASPE clubs. There are different activities that are held throughout the year in different colleges. We also assist states in drawing the state action plans. We are well aware that India has a federal structure and health is majorly on the state list. So unless we have state-level action against AMR like we have in Kerala right now, it's practically impossible to handle AMR. So we help states in with antimicrobial action plans. We also mobilize the society against AMR. There are several society organizations working in different areas that are related to AMR. It need not be necessarily AMR. It can be health, it can be wash, it can be immunization, it can be working with farmers. So we mobilize civil societies against AMR. So this is broadly an overview of what we do, and I would request all speakers and participants to reach out to us if it's anything that we could help as React. And I wish the workshop all the very best, and thank you very much.
Thank you, Ragini ma'am, for elaborating the activities of REACT for combating AMR. Any doubts, any questions from the audience?
I don't expect questions because this is not really a technical session, but thank you very much for the opportunity, and I'll stay on to listen to the other sessions.
Okay, thank you for collaborating for this workshop. Okay.
Our pleasure, ma'am. Thank you.
Thank you so much, ma'am, for sharing your valuable thoughts and experiences. Moving forward to the next session, we have Dr. Chitra Valsan. Dr. Chitra Valsan is an accomplished medical professional, earned her MBBS degree from the Government Medical College, Thrissur, and later pursued MD in Microbiology at AIIMS, New Delhi. She served her tenure at Amala Medical College from 2002 to 2006 and has been associated with Jubilee Mission Medical College since 2006. Currently, she serves as the head of the Department of Microbiology, Jubilee Mission Hospital, Thrissur. Driven by a keen interest in hospital infection control and antimicrobial resistance, she has dedicated her career to advancing medical practices in these critical areas. We invite Dr. Chitra Valsan to share her thoughts on the topic, infection control mechanisms in hospitals.
A very good morning to all. Thank you for the introduction. At the outset, I would like to thank the organizing committee for giving me this opportunity. So, I will be talking about infection control practices in hospitals. So, I will be briefly going through these objectives, the introduction, followed by mainly focusing on different components of standard precautions and a brief about hospital infection control program in all hospitals. So, as we have seen, antimicrobial resistance is a global crisis that threatens the medical world, and it has become very difficult to treat the common diseases, and also it is very risky to do life-saving medical procedures nowadays. So, the most important and most effective approach to control the emergence and spread of AMR is a strong infection control program in any hospital.
And we know that there are several risk factors for emergence and spread of AMR in healthcare setting. It can be overuse of antibiotics, mainly broad spectrum antibiotics, chronic patients with underlying diseases, critically ill patients, and high-risk units like ICUs, etc., where there can be a heavy load of antibiotics, which can induce a selective pressure in the bacteria and can result in the emergence of or selection of the resistant mutants. And so coming to the definition of healthcare associated infections. So these are infections occurring in any patient after 48 hours of admission, and the patient will not be in the incubation period of that disease at the time of admission. So these are the important pathogens in any hospital, especially in a developing country, which we are worried about. These are the main nightmares actually. Enterococcus faecium, which can be vancomycin resistant, Staph aureus, maybe methicillin resistant, Klebsiella pneumoniae is ESBL positive or carbapenem resistant, then carbapenem resistant Acinetobacter baumannii, then multidrug resistant Pseudomonas aeruginosa, Enterobacter species. These are all associated with infections, but these are all associated with high risk of mortality. And so how does an infection occur within a hospital? Sources can be many. It can be patient, it can be healthcare worker, it can be the visitors in the hospital or other patients, or even the hospital environment, or even from the community. So these are the 6 links for an effective transmission of pathogens to occur, or microbes to occur in any hospital setting. There should be an organism, a reservoir, a portal of exit, a route of transmission, and a portal of entry, and a susceptible host. So by adopting some infection control measures, you are actually trying to break the chain at some point. So implementation of standard precautions for all patients all the time is the key to preventing spread of all microorganisms, especially that of multi-drug resistant organisms in a hospital setting. So what are these standard precautions? These are actually a set of practices, infection prevention practices or guidelines, which you have to follow irrespective of the patient's infection status. So patient, you don't know that, whether the patient is infected or not, but you have to follow those guidelines. And there is another set of transmission-based precautions, which I will come later, and these have to be followed along with standard precautions in certain specific situations, which include contact precaution, droplet precaution, and airborne precaution. So these are the major components of standard precautions, which have to be followed in any hospital. The most important being hand hygiene and the proper use of personal protective equipment, respiratory etiquette, prevention of needle stick injuries or sharp safety, then cleaning and disinfection of the environment as well as the patient equipment, and biomedical waste management. So these are the major components of standard precautions. So your hands can carry different types of microorganisms, and so you can transmit these microorganisms from the patient to other patients to your hands. And so hand washing is the foundation of infection control. It is a cornerstone in any infection control program. And there are several substances, several products that can be used for effective hand hygiene. It can be a plain soap, it can be an antimicrobial soap, or alcohol-based hand gloves. We usually use alcohol, ethyl alcohols from 60 to 80% concentration, and chlorhexidine also has been used, some 0.5 to 4% in different situations. And then you have to do this hand hygiene. So WHO has identified 5 moments of hand hygiene that has to be done by any healthcare worker in a hospital setting. These are the key 5 moments that has to be where you have to do the hand hygiene in hospital. And so these are the steps of hand hygiene. I am not going into the details. This is also given by WHO. There are 6 steps of hand hygiene. And why you have to follow steps? Because if you are not following steps, you can miss many of the areas of hands. So that can be avoided by following these steps. So this is the culture of the culture plate showing the impression of one's hand, which is not washed and showing good growth of staph aureus. So there are several studies in the WHO side. You can see plenty of studies which shows evidence of clean hands in reducing the healthcare associated infections as well as multiple resistant organisms. And majority of these papers offer convincing evidence that improved hand hygiene practices lead to a reduction of hospital associated infections. And Didier Pitet, who was the main proponent of hand hygiene, has reported that the total cost of hand hygiene promotion corresponded to less than 1% of costs associated with nosocomial infections. And in our hospital we have trained all healthcare workers regarding the different products of hand hygiene, the agents to be used in hand hygiene in different situations, the steps to be followed, and the time also we have trained them. And we have to monitor the hand hygiene compliance in any hospital, because you have to know whether these programs are going rightly. So there are checklists or tools given by WHO again, which you can use for monitoring the hand hygiene compliance of different healthcare workers. But nowadays there are apps available which you can use very easily for monitoring the hand hygiene compliance. Coming to the environment, you should have a clean, dry and dust-free environment to prevent infections occurring within a hospital setting. So in this context, I have to differentiate between two types of surfaces in a hospital environment. It can be high-tech surfaces, which are the surfaces that have frequent contact with hands, like intravenous pump, bed rail, bed surface, supply card, computer keyboard, then phones, light switch, door knobs is another important high-tech surface. So in all these areas you have to do more frequent cleaning, and you should have protocols for cleaning of these areas also in your hospital policy. And there are similarly there are low-touch surfaces which are surfaces that have minimal contact with hands, like floor, wall, etc. So you require a cleaning on regular basis, not too frequent in these areas. And also you should train your cleaning staff or housekeeping staff in the proper method of cleaning also. Like you have to clean from the clean area to the dirtiest area, and from top to bottom. And also you should teach them to go in a methodical, systematic manner to avoid mixing of areas. In most of the floors you require only detergents. In ICUs and theatres you can use mild disinfectants also for cleaning of floors. And there should be, in your hospital policy, there should be clear written policy for environmental cleaning, the agents used, its concentration, and it should be associated with good training of these staff also. Now coming to the cleaning, disinfection and sterilization of patient equipment. So you will be using different types of equipment in the hospital, and they can be classified. This is called Spalding classification. So that is based on the risk to the patient. You can classify the different equipment as critical, which are devices that comes devices which come in contact with sterile tissue or blood stain, like surgical blade, etc. So in these equipment you have to use strict sterilization by autoclaving or ethylene oxide sterilization, plasma sterilization, etc. And there are certain equipment like which are semi-critical, which comes in contact with mucous membrane or non-intact skin only. So you can use high-level disinfection with glutaraldehyde, etc. These equipment. Then there are non-critical devices like your stethoscope, BP apparatus, etc., which come in contact with intact skin only. So you can use some low-level disinfectants or intermediate level disinfectants like alcohol or hypochlorite, etc. And quality check for each process is very, very important, and storage of these devices after sterilization process is also very important. Now the use of proper use of personal protective equipment. You will be using different types of PPE in a healthcare setting, like gloves, gowns, masks, goggles, face shield, depending on the type of exposure you are going to have, you can, and the indication, you can select these PPE to be used in different situations. And here also, you have to, while using PPE, gloves mainly, you have to work from clean to dirty and avoid touch contamination. While wearing gloves, you should avoid touch contamination, which means you should not touch your face or adjust PPE with contaminated gloves, and don't touch environmental surfaces except as necessary during patient care. And while using gloves, if the gloves is damaged, please don't use it. And it's not a good practice to wash the gloves and reuse it. It's not recommended actually. And in general, for all PPE, it should be donned before contact with the patient, generally before entering the room, and you should not spread contamination, and remove and discard carefully. Doffing should be done very carefully, otherwise you will be spreading contamination, either at the doorway or immediately outside the patient room. And once you have doffed, you have to immediately do hand hygiene. And the most important, please don't forget to wear it properly. And the other than standard precaution, I was talking about transmission-based precautions, which you have to follow along with standard precaution in certain special situations. Like if you know that the patient is diagnosed to have tuberculosis, you can follow airborne precaution, or the patient is contracting multi-drug resistant organism, infections with multi-drug resistant organism like ESBL positive or carbapenem positive bacteria, then you have to follow the contact precaution. So basically these are type of isolation precaution, and there are three types of them: contact precaution, droplet precaution, and airborne precaution. By contact precaution, you are preventing transmission of infections which are spread by either direct contact or indirect contact with the patient or patient's environment. And you have to use gown or gloves whenever you are entering. So ideally patient should be put in a single room, or you can do cohorting. I will come to that later. In droplet precaution, by adopting that, you are preventing transmission of infections which are spread by air droplets which are bigger in size, which are released by coughing, sneezing, talking, etc. And when you are entering in such a room with such a patient, you have to wear surgical mask, and the patient should be preferably kept in a single room. And the third one, which prevent the airborne precaution, which prevent the transmission of infection that remain infectious over long distances, which are transmitted through small droplets less than 5 micron in size, which can remain suspended in there and can be taken to long distances, like for example tuberculosis. So if such patients are there, you have to wear, the healthcare worker have to wear N95 or respirators, and the patient should be placed in special rooms like airborne infection isolation room with negative pressure and special ventilation. So these are some of the diseases for these examples for these precautions. For contact precaution, in cases like MRSA positive patient, diarrhea, C. difficile patient, droplet precautions have to be taken in patients with pertussis, diphtheria, then mumps, etc. Airborne precautions, most important nowadays in our setting is tuberculosis and chickenpox, then H1N1, then measles and disseminated herpes. So I was talking about cohorting. So it may not be possible to give single room in most of the hospital settings. So you can place patients with similar diseases like MRSA positive patients or ESBL positive patients can be placed in a single room. So who are colonized or infected with the same organism can be placed in a single room, and of course the room should be having dedicated staff. The staff should not be sharing with other patients, should not be sharing with other patients, and visitor restrictions should be there. And as far as possible, you have to use single-use items, disposable items. Patient items also should be dedicated, like thermometer, stethoscope, etc. should not be shared with other patients, and cleaning should be adequate. So that is what you call as cohorting. And CDC had given these posters which can be pasted on the door when such patients are put in such isolation facilities. So when a healthcare worker is going to enter that room, they can just go through that and have an idea what are the precautions that they have to take. So this is for contact precaution. This is for droplet precaution and for airborne precaution. I am not going into the details because of shortage of time. Then coming to the surveillance of multi-drug resistant organisms. In Western hospitals, Western countries, they are routinely doing surveillance for multi-drug resistant organisms in most cases. But in our setting, we do not routinely do. Sometimes we do screening for MRSA, especially in cardiac patients undergoing cardiac surgeries, etc. And if found to be MRSA positive, we advise decolonization with mupirocin 2% mupirocin before the patient is taken for surgery. And then another aspect of standard precaution, another component of standard precaution is prevention of needle stick or sharp injuries. It is very, very important because that is one source where healthcare worker can contract many bloodborne infections, bloodborne viruses. So there should be puncture-resistant container for disposal of sharps, and you should teach all healthcare workers that recapping should be avoided always. And there should be a written hospital policy related to this. And so this is the policy in our hospital. So what has to be done in case of occupational exposure like splashes or needle stick injuries, what they have to do, whom to contact, and what are the steps to be taken next. So such things should be clearly written in your hospital policy. Then another component of standard precaution is respiratory hygiene or cough etiquette. So you have to train your healthcare workers and patients to cover their cough using elbow or with tissues, and the tissues should be discarded properly, or your hands should be washed properly after that. And for patient placement in hospitals also, it is ideal to have a separation of 1 meter between the beds to prevent transmission of agents from one patient to another with proper ventilation and all. And then about safe injection practices, you should not reuse syringes or needles. Use sterile disposable syringes always. Then use single dose vials as far as possible. Hospital waste management, biomedical waste management is another important entity in hospitals which has to be taken care of, and there should be clear written policy for how to, and we have such posters in all areas showing which waste has to be discarded in which color-coded bin like that, so that it becomes easy for disposal, and mixing of waste should be avoided to the maximum. Now, coming another important area is surgical site infections, operation theatres. So in operation theatres, the major source is from microscopic skin fragments from staff or patient, and another important source is from air also. So it can enter the patient's wound, surgical wound, through airborne or contact transmission. So these are some of the practices to be done to reduce surgical site infection. The preoperative stay in ward should be minimal as far as possible, and in diabetic patients, blood sugar levels should be controlled on the day before surgery, and stop smoking or alcohol. Then hair clippers are used instead of shavers, and preoperative chlorhexidine showers also is of help. Then in the well-engineered operation room is also very, very important with good laminar fluid ventilation system, and a positive, the OT should be positive with positive pressure, and have HEPA filters, and good air handling units should be there. And proper maintenance of air conditioning is also very important. And most important is to limit the number of patients in the theatre, and the person movement also should be restricted. It should be minimum to reduce the air currents and surgical site infections which follows. Then intraoperative practices also is very, very important. Minimal blood loss, and gentle handling of tissue, and proper sterilization, disinfection of equipment, surgical equipment, very important. So why should there be a hospital infection control program in any hospital? This is a mandate by NMC for all medical colleges nowadays. So studies show that nearly 1/3 of hospital-associated infection can be prevented by a well-organized infection control program. So these are the main areas of activities of a good infection control program in any hospital. Surveillance, you have to, you won't look at it if you are, you won't see it if you are not looking at it. So surveillance is very, very important. Then feedback, proper guidelines for antibiotic use, policy development, management of outbreak, then training and education of staff. And so you should have, all the hospitals should have a manual also, hospital infection control manual also. There are good references now available, CAIOC and by National Health Mission or ICMR manuals are very good ones that you can follow. And there should be a hospital infection control committee for all hospitals as mandated by NMC nowadays. So it should have members from all sections of the hospital, and there should be an infection control doctor and an infection control nurse, which should be proportionate to the number of patients. And they are actually the pillars of hospital infection prevention program. Then, so these are some of the activities of the nurse and the doctors, infection control doctors. They will be taking daily rounds, and then environmental sampling also is done sometimes, especially in outbreaks and all. Then statistics, and they will be presenting the data in periodic meetings, and gaps are discovered and corrections are done. And formation of antibiotic policy is also one among the activities. So last a few words about antimicrobial stewardship program, which is very, very important in this context. So as definition, CDC has given it as the use of right antimicrobial agent for the right patient at the right time with the right dose, route and frequency, causing least harm to the patient and the future patients. So you have to formulate or each hospital has to frame their own hospital antibiotic policy based on their local antibiogram. So you should know your hospital antibiogram first, which is actually the compilation of the different bacteria which have been isolated in the last 1 year or 6 months, and the sensitivity pattern in different infections. So these are some of the antibiogram, and this is how we have made our antibiotic guidelines. So there are state antibiotic guidelines, national guidelines and international guidelines which you can follow to formulate your antimicrobial, or the base with which you can formulate your antimicrobial policy for your hospital based on your antibiogram. And once a draft is prepared, you have to sit with all the departments and make discussions, and inputs are taken, and it is finalized later. And also it is updated every year as per the changes in the antibiogram also. So these are some of the references which we have used for formulating our antibiotic guidelines. So the guidelines contain suggestions for empiric therapy, the targeted therapy. So once a culture has grown something, what has to be done, which antibiotic has to be given. Then surgical antibiotic prophylaxis also will be included in the antibiotic guidelines, and some antibiotics we have kept as restricted antibiotics in for our hospital. So there is a policy for the use of such restricted antibiotics, and periodically we do antibiotic audits to see the compliance of the doctors to the antibiotic usage, and give feedback also to them if there is a need for correction. So we have to check whether our hospital infection control program is going properly. So we should find out some indicators, quality indicators, to assess the performance of our hospital infection control program. So we have taken these infections rate, like ventilator-associated pneumonia, surgical site infection, catheter-associated urinary tract infection, central line-associated bloodstream infection. We have proper guidelines for the prevention of infection in these situations, which are called care bundles. And we track the infection rate in our hospital for these infections, and also occupational exposures like needle stick injury or splashes, and of course hand hygiene complaints. And we present the data in the meetings, and gaps are analyzed and corrections are made. And we identify hand hygiene champions also in different categories of healthcare worker to motivate them for for adhering to hand hygiene compliance or improving hand hygiene compliance. A good microbiology lab is very important, a 24/7 lab, which helps in rapid diagnosis and initiating infection control measures if needed. It's very important. And also doctors also have to be given awareness regarding the culture of developing the culture of culturing. Like they have to send the cultures or microbiological investigation should be sent before antibiotic administration. Adequate sampling, proper sample in adequate amount has to be sent. And how to differentiate between contaminants and colonizers from the culture. It's also very important before starting the antibiotic therapy. So to summarize, strict adherence to the following measures are very important to reduce hospital-acquired infections and spread of AMR. The most important being hand hygiene in any hospital setting, and then followed by environmental hygiene, screening and purporting of patients, surveillance, good antibiotic stewardship program, and the following guidelines and safety cultures. So thank you.
Thank you, Chitra. Chitra is very active and efficient in HIC, and Chitra gave a beautiful narration on how to break the chain of transmission in hospitals, particularly as standard precautions with the stress to hand hygiene, and also the quality indicators always we get a best on this hand hygiene surveillance in the hospital. Okay, any questions?
Madam, how frequently is the high-touch surfaces being disinfected? In our hospital, as per the policy, we have to clean it every 3 times per day. 3 times. And the staff has been given checklist also, so they just enter in the checklist whenever they have done that. So that is our hospital policy.
Thank you. Can you please explain the protocol that you were mentioning about the 2% treatment just before the heart surgery?
So what we do is we do cultures from the nostrils, axilla and groin, and if it is MRSA positive, then we suggest decolonization with 2% mupirocin 2 times for 5 days. Then also chlorhexidine rubs also solutions are also available. They can do scrub with chlorhexidine and decolonization can be done. You have to check also whether it has been removed after 1 week, because
it's done 1 week before the surgery.
Yeah, it is ideal.
Chitra, I have a question. Do you screen the patients transferred from other hospitals for MRSA?
Not routinely. Only if they are undergoing some special procedures like I told you, cardiac surgeries or.
Okay, Dr. Chitra, I think it was a very informative presentation from your side. What I would like to know is, from your presentation, you said that, your doctors have been cultured into sending their cultures. Now, what percentage of doctors they are sending these? No, I'm just asking you from your experience.
But
because that is the culture which we want to inculcate in them.
We ask for if it is not done properly, we call them back and ask for a good sample or there is a lot of things.
Now, what is the what do you call it? Percentage? How much you have? Maybe 50%. That is too much.
60%. Maybe.
No, from your experience, I'm just
50 to 60%.
No, otherwise we need to work on that. That is why I'm just asking.
Those who actually look at the culture report, who practice evidence-based medicine, they follow us. Whatever we say, they follow. They tend to follow. Otherwise, other people, they don't look at the culture report also, just sending culture. But nowadays there's a lot of change. People are going for practicing evidence-based medicine nowadays because it's become a problem. No, they asked us to document it in the case sheet. Please give us the time. We have to write in the case sheet also sometimes.
Right. Okay, thank you very much.
Are the alcohol-based tablets better than hand washing? In one slide it was mentioned that
Actually, alcohol-based hand drugs are better
than hand washing.
Yeah, hand washing, it helps to remove that transient flora, and alcohol-based hand drugs helps to destroy some of them also. Along with removal, it destroys this transient microorganisms, which may be sometimes multi-drug resistant also. So it is said that this is better than plain soap.
That is done.
Yeah.
MRSA, all MRSA patients together, whether that is practiced like
Not all we won't be having that much number of MRSA patients.
not only MRSA, like that whether that practice is there regularly in hospitals, that this antibiotic resistance patients are together, like that it is whether it is regularly practiced.
It may not be regularly practiced, but when situation rises, you may have to do sometimes. Because in our hospitals, you may be knowing, it's a poor man's hospital, so it is not possible for the patient to occupy a room, single room. So if there are two, we can put them in a single room. That's all. During COVID times also, the government was advising this for holding all are COVID positive, so they can be put in single room.
I got a question. Actually, I have two questions. One is more related to the antimicrobial resistance in the hospital setting. You are working as a microbiologist in the hospital. There are so many hospitals which follow this stringent protocols, and there are stringent protocols. I think most of the private hospitals they follow it, and in government sector, I'm not blaming them. But they are not following the pattern. Is there any study which state that is there any statistical significant difference in the death rate due to the antimicrobial resistance in such two different setups? Have you come across any study like that?
There will be definitely, because it was not in my topic, so I didn't
Yeah,
say those things. But definitely there will be studies. It will be like that only.
So
If you are following antibiotic guidelines strictly in your hospital, you can reduce antimicrobial resistance. And because, for example, nowadays many doctors tend to give piperacillin tazobactam. Once a patient comes to the hospital, they start with piperacillin tazobactam. But that is actually an inducer of carbapenemase enzymes. So many times when the patient actually develops infection, you won't be having any carbapenem to treat the patient. So it becomes a very difficult situation for the patient. So if that doctor would have practiced strictly followed the antibiotic guidelines in that condition, he would be reserving piperacillin tazobactam for.
I'm not asking about the antibiotic usage. I am asking about the hospital management system, like how you maintain the sepsis and such conditions, not the antibiotic.
Yeah, it will be definitely like that only. Hospital with good hygiene practices and all will be having lesser infection rate, as well as I think that is what you meant.
Yes.
It will be definitely like that. There will be plenty of studies.
In India, we don't have any study. I didn't come across any study, but in Europe,
there are many intervention studies, before and after studies are there based on these. So they have reported that after intervention, proper education and training, definitely the rates have come down. There are many reports.
second question is as a practicing clinician, is there any problem with the antimicrobial resistance in the treatment sector? Is it due to the bacteria becoming more active, or are we becoming less resistant?
As ma'am said, the antibiotic resistance will be it will be more with the more exposure to antibiotics. So the more the exposure to antibiotics, the more the sensitive strains will die fast, and the resistant mutants will propagate. So it becomes difficult then to control the infections. I hope.
Actually, whatever the antibiotic that you give, that kills only 40% of the pathogenic bacteria. The 60% of the other bacteria, pathogenic bacteria I am talking about, should be killed by the innate immunity of the body.
That is there.
So, is it really because our innate immunity is reducing rather than bacteria becoming more resistant?
In a hospital setting, especially chronic patients and those with immunocompromised conditions and all, the immunity will be very reduced and we have to depend on antibiotics.
I am asking about the herd immunity, not the immunocompromised. That's a special population.
In the hospital, once you get admitted to a hospital, within 2 days your normal flora becomes replaced by the hospital flora. And this is you are always at a high risk.
Yes.
So you have to depend on your immunity. Maybe immunity is definitely an important factor, but sometimes it may not be the sole factor in recovering you. Like you have to depend on antibiotics. So immunity is a prime, that I agree. In all conditions, you cannot depend on immunity.
Ma'am, just want to know about whether is there any some protocol for this pharmacy waste like the expired antimicrobial agents, is the expired antibiotics, how it is being processed, means how it is being managed.
What we do is we just return them to the company.
No, after that, do you have any idea that after that how it is, what happens to these expired antimicrobial agents?
I don't know actually. What in our practice, like in our hospital, we send them back to the company.
Ma'am, in your slide it is very clearly mentioned that airborne is a very big threat to this kind of AMR. But what are the measures?
AMR, the multi-drug resistant like bacteria, is mainly spread by contact, direct or indirect contact. Airborne has limited role in that.
My question, what are the measures normally practiced in hospitals to control the microbial viral load or bacterial load in a airborne way?
And it may be different in different situations. So like if a patient is positive for tuberculosis, we keep that patient in a single room. Preferably, it should be in a, like I told you, in an airborne isolation room. If it is not there, you can just place an exhaust on the opposite side and keep the doors closed so that some sort of negative pressure is created.
So keeping an exhaust means spreading the whole thing to the total.
No, exhaust is actually like going outside. The vent should be going higher. It should not be facing the other building or like that.
So normally ICUs and operation theatres where we can find a lot of microbials, which may be AMR or normal. So what are the measures we are making to reduce the viral load or bacterial load in that? That should be in your hospital.
Frequent cleaning is the most important thing.
Airborne. Airborne.
For airborne. HEPA filters are there in some hospitals for ICU and all, but we don't have.
There are a lot of studies that HEPA filter is a source for.
It can be. When it's not properly made, it can be again a source. It should be cleaned as per the manufacturer's instruction. Maintenance is very, very important.
Operation theatres are different for different category. If it is infected wound, that theatre is different.
Yeah,
if you operate on a gas gangrene patient, that theatre is not a routine theatre we are using for other surgeries.
After one patient, the turnaround time for the next patient.
That is why it happens to the ear.
So such infected cases will be usually taken as a last case. Or after that, only after fogging, like if it is an airborne case, fogging will be done sometimes. Even though it's not recommended, we do fogging, especially if it is such a case. Mainly for airborne, what we are doing these things. Thorough cleaning is very important because most of the drug-resistant bacteria is not spread by airborne, mainly by contact, direct or indirect contact. Thorough cleaning will suffice.
any policies or guidelines pertaining to the residues of pharmaceutical waste, hospital wastewaters?
Sorry.
In means the pharmacological residues in the hospital wastewater. Is there any policies or guidelines which is practiced or
That is in our hospital, it is going to the STP. I don't know for if there is a policy. Maybe pharmacology people may be more able to tell about that. Recycling will be there. STP, sewage treatment plan is there, and that is what.
When you are sending to STP, you are again
that's
creating
Yeah.
That's what I asked before that. Expired antimicrobial which is being given back into the environment itself, creating a problem.
Sure.
The same some policies are there to break the stain. That's what just want to know for that.
There has been a comment in the chat box session. So, Dr. R.N. Naidu has commented that excellent presentation, doctor. He has a query. In spite of following your suggested guidelines, many patients are dying in ICUs because of healthcare associated infections. Why?
Same thing, antimicrobial resistance, you have to control it. You have to make it more sensitive by judicious use of antibiotics for the future. That's all. Thank you.
Thank you so much, ma'am. This has been a very informative session. Thank you so much, ma'am. The next session will be handled by Mr. T.K. Prakash, Managing Director, Archer Diagnostic Private Limited. T.K. Prakash holds a distinguished BSc in Zoology from Calicut University and boasts a robust career spanning both the pharmaceutical and diagnostic industries. With 14 years of experience in pharmaceuticals, including managerial roles, he transitioned to diagnostic, founding Archer Diagnostic Private Limited in Kochi in 1989 and later became a director at CPC Diagnostic Private Limited in Chennai, retiring in 2014. His contributions to the diagnostic field are monumental, marked by pioneering efforts in automation, enzymatic kits, and quality control systems. Notably, he introduced preventive maintenance concepts, third-party quality control systems, and played a pivotal role in advocating for pre-analytical automation internationally. His proactive approach extended to certifications, guiding healthcare providers towards ISO standards and acquiring certifications himself in quality management systems. Mr. Prakash's international presence spans conferences in Germany, USA, Japan, Dubai, and China, coupled with extensive visits to study pre-analytical automation in various countries. Additionally, his diversification into the field of disinfectants and active involvement as expert faculty for certification programs further underscores his multifaceted expertise and industry influence. We welcome Mr. T.K. Prakash to discuss on the topic citrus flavonoids, a potential tool to tackle antimicrobial resistance.
Good morning, all of you. Let me thank the organizers for having given me this opportunity to address you. Basically, in the first few slides in this, I'll be rushing through because it has already been touched upon by earlier speakers. AMR is only natural because it has already been underlined effectively. So our role is rather to accept that this is a part of life and there is no special status for human beings on planet Earth. So we have to manage our resources and our approach judiciously. Other aspects has already been like RD, ZDT, all those things has been touched upon. And human triggered rather than the natural, now our critical area now is the human triggered AMR, where the incidence is more intense and probably we need to look for viable and sustainable solutions. Here the last 4 years that exists as commensal in nasal mucosa, over 30% population has also developed penicillin resistance. So, and nosocomial infection, most of the things, back strains are MDR now. Methicillin, it started as a designer antibiotic, but in flat 3 years, the resistance developed. And another interesting thing, in 2005, that press report that 100,000 Americans stricken with MRSA infection and some 20,000 died. More than the amount of people who were dying from HIV, TB combined, according to Harvard magazine. These are all the scenario regarding AMR. And TB, most of the, now it is multi-drug or extremely drug resistant. And the current regimen is BPAL. I think we don't have to go into the details of that because that is not the scope of the discussion. One interesting thing in this slide is that Pretomanid, which is part of the BPAL, has been developed by not a drug manufacturer. It has been developed by a TB Alliance not-for-profit organization. The point is, antibiotics research, pharma companies are not willing to put money in because of the AMR issue, because they can't make profits over a long time. And last 40 years, only 3 new drugs has come in for TB treatment. Here again, the points has already been touched by others. One interesting aspect is ESBL E. coli constitutes 10 to 12% of bacteremias in UK, whereas it is 50 to 80% in India and China. And pipeline for new antibiotics again has been highlighted by previous speakers. So we'll go to the next. This aspect also has been touched by people, so the various modes of drug resistance. Again, caused by overuse, underuse, as misuse, and anthropogenic use in antibiotics. In anthropogenic use, apart from the AMR, I would also like to mention about our mad cow disease, spongiform encephalitis, which again was due to anthropogenic use of feeding them with animal products. It is again the root cause of all this is our avarice. And monedial superinfection and Clostridium difficile infections are clearly product of antibiotic use. Because bacteria, the antibiotic destroyed bacteria, normal flora, and Candida started overgrowing. So it is clearly a man-made disease. Likewise, Clostridium difficile, which was a minuscule proportion of the normal flora, became overgrown and unfortunately became mostly resistant to existing or available antibiotics. And it is this Clostridium difficile infection which started the practice of microbiome transplant or fecal material transplant some 10-12 years back. Now it has come to such a level that within 10 years, even US FDA has approved fecal matter capsules for treating. We have come in such a short span of time, we have come to that. And I think this this practice is being done even in Kerala hospitals now in selected areas. See, the problem is such a drastic step had to be resorted to. So in this context, my thought was to, or ancient wisdom of using cow dung. Because not cattle feed fed cows, grazing cows dung, probably that was microbiome transplant. I don't know. This is one aspect. There are so much of work going on. Everywhere it is data surveillance and data compilation and data crunching. I don't see any specific specific steps in the direction of decelerating or controlling this problem of AMR other than discrete use or restricted use of antibiotics. And I'm attempting to postulate or propose a paradigm or a working model to intervene in the current spiral. Here the targeted, I have put in inverted commas because that is not in the present context that word is used. Now targeted therapy is where your drug acts only at the site of action. That is not meant at that. They simply targeting, we give antibiotic targeting the pathogens. So only in that sense it is used there. And here the point is, we have to, my request to the group is that what we are suggesting or postulating, whether it has got sense or not, please evaluate and tell us. The microbes that carry the memory of onslaught on repeated exposure could make incremental improvement in development of defense against the antibiotic in use. Over repeated cycles, this becomes a full-blown resistance. Because resistance is not at one go, it doesn't become a resistant strain. I think it takes some time. So it has to be due to gradual process. So, as mentioned in the last point, please evaluate and tell us whether this suggestion or proposition has to be debunked or has to be evaluated further. Citrus flavonoids to how and why. This citrus flavonoid or citrobioshil is found to be totally potent against bacteria, virus, fungi and evidently safe on humans and instruments. Still, its potential is hardly recognized and harnessed. So, before launching, of course, the manufacturer has developed enough, put together enough in-house data on its efficacy and safety, but I am not going to go into all that. Whereas I am going to project only one or two slides where it has been evaluated by third party, outside party. This is a report from CIFT, Central Institute of Fisheries Technology, where the effective concentration for bactericidal and fungicidal aspect has been studied. It is seen to be effective against even MRSA and even many other, almost all human as well as fisheries and veterinary pathogens. Then yeast, molds. Now, this is a report. Sorry. This report is, this table is from a not yet formal study. I received it only 2 days back from All India Institute of Medical Science, New Delhi. They did fogging and studied the effect on surfaces, floor, open air in gram-positive, gram-negative pathogen. Formal report is yet to come. That's why the name of the author of the study is not mentioned. So it is found to be effective. The pre-fogging and post-fogging reduction shows that. And the distribution of environmental isolates in the same study. There is 100% reduction in most of the colonies, and there are colonies totally unaffected also, but colonies were little small, 3, and they are all harmless ones. Okay, shall I go to the next one? This in silico study, where naringin, which is one of the important constituent of citrus bioflavonoid, is seen to be superior to 53 other natural ingredients in inhibiting or Nipah virus, and it is better than the control antiviral ribavirin. TGA, that is Therapeutic Goods Administration of Australia, has granted virucidal status to similar combination because it's effective against parvovirus. That is the most stringent criterion they have for granting virucidal status. Apart from those, there are a number of virucidal activity on most of the current pandemics. It also qualifies as a sterilant because on contact it destroys the reference material Geobacillus stauromophilus spores. So far, so much about its efficacy. Its safety profile. CTRI has done and CTRI registered study was conducted in Pune during COVID period. An interventional trial for inhalation of the bioflavonoid in mild and moderate COVID-19 patients to evaluate the safety and efficacy of citrobiosil. And its safety profile is established as claimed in the MSDS of the product. Efficacy, it's only one study and only about 19 patients. There has been no adverse effects. That much, and this study is available for anybody to access in the CTRI website. It's a 63-page report on the study. It's a full-fledged study. It's an antioxidant, non-inflammatory, non-corrosive. Probably the only antioxidant disinfectant, and probably the only disinfectant without a hazardous material label on it. There are no precautions, no caution advised. And it is food grade, known to inhibit ACE2 receptors. So naturally, this could be a therapeutic agent as well in some conditions. It's too premature to claim all this, I accept. But whether it is worth looking at is the only proposition, nothing else. presumably increases IgA because there, again, not enough study has been done. IgA level has almost doubled when this was sprayed into the buccal cavity. So ultimately, if the virus is tackled in the upper respiratory tract infection in the throat itself, ultimate complication once it goes to the lower respiratory tract is actually preempted or avoided if it is handled when it is still in the upper respiratory tract, because it gives about 4 or 5 days time. It is alcohol free, non-flammable, devoid of any smell. So that is an ideal candidate for spraying or sanitizing the car interior. It is safe. And while doing the fogging of ICU, OT, etc., there is no need to cover any appliances or instruments. So in effect, it's a total sterilization of the premises. Nothing is left untouched. You can just leave everything open and do the fogging. And its residual action on inert surfaces makes it impossible for the escaped bacteria to colonize, work on its defense and go to the next victim. So escaped bacteria from the antibiotic treated patient will not be able to continue the cycle of development of resistance. RTU is ready to use MICROBIAL because a 10% ready to use form is also available, whereas for fogging and all, 100% concentrate is given. That is to be diluted as per requirement. Usual requirement for critical, semi-critical area is 10%, whereas for spores, 20% is recommended. This I already mentioned, helps to exterminate the microbes as they colonize the upper respiratory tract. Obviate the use of antibiotics, prevents transmission to others and fully breaks the chain. Because in pandemic situation that is what is required. And in alcohol-based sanitizers, I don't think we were actually breaking the chain. What was the position of the airborne, the phase during the airborne transmission? First of all, it has to come from a reservoir and has to reach the next victim. What happens in between that? Do you have anything? You can't put an alcohol spray on your mask. You can't spray the air because it's bad for people. And by killing the bacteria in transit or virus in transit, it is blocking or preempting the scope of AMR genesis itself. And during those days, pandemic days, everybody were wearing masks, but normal mask can, the microbes can penetrate and reach. Whereas if you spray it with a product like MICROBIAL, it is safe to be applied that way and it could have broken the chain in effect actually. And AMR, what could be the genesis and progression of AMR? Hospital is the epicenter of human-triggered AMR. I think there is no dispute about that aspect. Natural AMR, we are not in the picture at all. Patients admitted to disinfected ICU or ward start shedding microbes through breath, body fluids, wounds, secretion, etc. to their air, in the air, bed linen, pillows, surface, room and toilet. Microbes emanating from the patient is pre-exposed to antibiotics inside the patient. Those that manage to survive and come out will carry the memory of the assault. Survival instinct make them devise protection because it's the survival of the fittest in any case. So it is bacteria's job to develop resistance or any microbes. This is the proposition I said. I request the group to evaluate and say if there is sense in it or it is absurd. If you say it is not sensible, well, that is the end of my talking or trying to propagate this thought. Because now regarding the process of sterilization of hospital scenario, even if it is done 3 times, we cannot see in the presence of patient, there is no fogging or aerial disinfection possible. It is only the usual routine once a day or 8 hours or whatever is the frequency that happens. Even then, the bed linen, body of the patient, below, all the and the surfaces, especially in airborne diseases, this goes on. They permeate even to the permeate. Apart from the hospital, they can permeate through the visitors or whatever. Yeah, normal disinfection doesn't involve air disinfection. So to intervene, the only way is to do air and surface disinfection through fogging in the presence of patients is one logical and effective solution. And this could be planned, a comprehensive disinfection process could be planned based on the estimated microbial load you want to handle. And through programmable humidifiers or fogging devices or even manual fogging. To our knowledge, CDC or WHO has not designated any disinfectant safe enough for fogging in the presence of people. So why not critically evaluate citrobacter, which is already validated for the task? Citrobacter acts on contact, unlike antibiotics, which takes time because it interferes with the cell synthesis, either as a bactericide or a bacteriostatic. Citrus flavonoids acts on contact, destroying microbes emanating from the patients, and which is key to combat man-made AMR. I am through. Thank you.
Thank you, sir, for giving a detailed description of the product CitroBioShield and its multitude of applications. Now the topic is open for discussion.
Can you tell me what are the ingredients in this one? What may be the probable active ingredient in this one?
It is only citrus flavonoids, that is orange, whole, then sweet lime rind extract, then lactic acid, citric acid, and one more organic acid, lactic, citric, and Anil, what is the other third acid? 3 organic acids plus there is nothing else plus a tinge of glycerin, plant glycerin.
What about the toxicological studies?
That is why I said to get the license, all the mandatory toxicology studies have been completed, animal studies have been completed. Only after submission of all those data, the license has been granted. And because it is a licensed product, and if you go to the CTRI study, you will find that whole lot of parameters, hematocrit as well as enzymology studies has been done in all the patients who were exposed. Full blood picture plus other SGOT, SGPT, such matters have been studied, and there have been no adverse effect at all. And in animal studies, heavy dose inhalation and necropsy also has been done after 15 days. Plus there is no LD50 dose.
So, one more. So, do you claim that you do not develop any resistance?
I'm not making any claims. This is only a proposition because the logic, it's only logical. It's up to scientific community to evaluate and decide. Because it kills on contact, where is the time? Even that viral, steriline thing, it is exposure of 5 minutes and 10 minutes. Actually, the effect is the same.
Oh, I am asking is, you are saying that it is isolated from the citrus fruits.
Yes.
They also undergo rotting.
Pardon?
They also rot.
Rot. Yeah.
Because there will be bacterial contamination.
Yeah.
So can you clarify?
But the point is, I presume that rotten oranges are not used.
No. I'm telling that bacteria can survive all the process of these materials. But you are claiming that is presenting this drug.
That is true. So your question is with this again, the studies show that nothing is growing. Plus, it has got at least 36 hours residual action on inert surfaces. You fall, you study the surface, inert surface, nothing grows. That orange game should have I am not able to, because formal this thing has not, I have not put their name. Now they have to, and that study has been done in 3 separate times by 3 groups on 3 days, and compiled the more. This has no enough data to claim anything other than efficacy and safety. Whether it is applicable, for example, my request to the host is, we have no data on its action on rabies virus. Why not find out? We don't have the wherewithal to go all out and study it. Studying it further, its application, potential use, it's up to the either government or healthcare sector to do. And I said it's only a proposition at the outset itself. Any more questions? Okay, thank you.
Thank you so much, sir. The next session will be handled by Dr. Tom C. Joseph. Dr. Tom C. Joseph serves as a principal scientist within the Microbiology, Fermentation and Biotechnology Division at the ICR Central Institute of Fisheries Technologies in Cochin, India. He holds a bachelor's degree in veterinary sciences from CVS Manati and a master's degree in animal biotechnology from the Indian Veterinary Research Institute. Dr. Joseph earned his PhD in Marine Sciences from Cochin University of Science and Technology. With 26 years of research experience, his expertise lies in seafood-borne pathogens and molecular microbiology. His ongoing research focuses on bacteria with public health implications in seafood and the development of aquaculture probiotics. Over the course of his career, Dr. Joseph has led numerous nationally and internationally funded projects. We invite Dr. Tom C. Joseph to speak on the topic Status of Antimicrobial Resistance in Fisheries Sector.
First of all, I'm thankful to the organizers, especially Dr. Sunil, for inviting me for this talk. See, this is one area, the aquaculture, the fisheries is one area we often don't consider when AMR is considered. We normally limit our, talk about AMR with regard to human health or animal health. It doesn't include aquatic animals or the water as such. But the thing is, today I'd just like to take you through how the water systems, the aquaculture systems influences or how much AMR is being transmitted by aquaculture operations. With that, I'm sure that this slide has been shown before also, but then Alexander Fleming, when he discovered penicillin in 1928, he said, when I woke up just after dawn on 1928, I certainly did not plan to revolutionize all medicine by discovering the world's first antibiotic or bacterial killer. But I suppose that was exactly what I did. So the World War II, when it happened, millions of people were saved because of the discovery of penicillin. But later on we know that the penicillin has become resistant to many of the organisms to which it was treated, especially the gram-positive bacteria. And within a year of its introduction, bacteria started developing antibiotic resistance. So that's how people started thinking of newer antibiotics, and then we know the discovery of antibiotics. There's a big gap. As earlier speaker was also telling, there's a big gap, and especially because the drug companies doesn't want to invest, or maybe because we are short of antibiotics. Whatever way it is. And we always tell that, cancer is the biggest killer, but then it is predicted that by 2050, around 10 million people, that's a big number. 1 crore people will die of AMR infections. And that means 1 person per 3 seconds will die just because you don't have a treatment for the infection. Earlier, AMR was in the books only, but then now we realize that AMR is near us. In our office itself, I know at least 3-4 people who have been infected with AMR pathogens. And sadly, 2 of our colleagues' parents died because of AMR pathogens. So that means it is near us. Earlier it's like COVID when it came. Earlier we thought it was someone else's disease, but then later on it came close to us and all of us has got infected. It's almost similar to that, where we are sure that sometime or other we will get infected with AMR pathogens. And there is an estimate which says that in 2019, it has come in Nature, where it says that around 5 million deaths were associated with bacterial AMR, including 1.27 million deaths being directly caused by it. So that means it's just by infection alone. So it's a big number, and it's going to increase definitely. And when we take, normally we say that antibiotic is more used for human or animal health care, but then when it comes to the usage of antibiotics, it is expected to increase by 6 to 7% in 2030, and then predominantly due to the unsustainable intensification of food systems. Even when you take aquaculture, maybe early 90s, that is when intensification in aquaculture started in India. Earlier it was very extensive systems, just like we have backyard poultry or where you have livestock, maybe 1 or 2 livestock. Similar situation was there existing even in aquaculture also, wherein it was a very extensive system wherein, you might have heard of Pokali systems wherein you don't give any inputs into the aquaculture ponds, but then later on intensification happened in 1990s, and then diseases came in the 1990s, mostly viral diseases, but then what happened is people started using antibiotics. I just remember a thing which has happened when we studied. We wanted to try a probiotic in an infection in shrimp in a hatchery. So we were just doing that, and we were feeding the probiotics every daily. It was being fed, and we were trying to re-isolate the probiotic from these shrimp. Then, however we tried, this bacteria, we were not able to re-isolate the bacteria. So we were just thinking, what has happened to this bacteria which we have fed? So we started talking to the manager. We started talking to the people who were taking care of the animals, and then they said, no, we are not using antibiotics. And slowly we befriended them, and then later on he took up 4 packages, 4 different antibiotics that were being dumped into the hatchery. So that means the use of antibiotics is very, even though people say that use of antibiotic is totally banned in aquaculture systems, but then people use because it's freely available. And one of the things is that when you always talk about AMR, environmental sector is never integrated into the AMR national action plans of many of the countries. And that is where aquaculture stands, because aquaculture is part of that aquatic environment, and which is rarely considered when you consider the AMR national plans. Just want to introduce about the aquaculture production. The global aquaculture production is around 214 million tons in 2020. And aquaculture representing 49.2%. So that means it's almost equal. The captive fisheries, that means we go to the sea or maybe the backwaters and catch fish. Earlier it was around 70-30. When we started it was 90-10, then slowly. Now it is almost, aquaculture is the mainstay in fish production as far as fish production is concerned. And India is the second largest producer of aquaculture food fish, which is we contribute around 11.16% of the share. And we are second, and China is far ahead with around 30% share. And the Asian countries itself contribute around 70% of the total production. And we have around 16.24 million tons of aquaculture production. And it is estimated that the aquaculture production will increase by 42% in India and 32% throughout the world. So this is about the aquaculture production, the captive fisheries and aquaculture production. You see that, after 1990, the captive fisheries has stagnated. Whether it's inland or marine waters, it has almost stagnated. But when you see the aquaculture inland waters, it has been steadily increasing, and you can see the growth. It's growing at around 5% per year. So when you consider the production, China, you can see that there was a drastic increase in production after 1990s, and you see that the aquaculture of the inland waters has drastically increased, and the production of China is much more than all the Asia together combined. So you can just imagine how much China has progressed in terms of the production in aquaculture. So when you see the consumption statistics, we can see that India is a poor consumer of fish. It is around, as far as consumption of fish is concerned, we are poor. It is around 6.76%, because most of the people, especially people in the north or the west, they are mostly vegetarians. And when you take the global average, it is around 20 kg, but then you take Iceland, Maldives, it's around 80 plus. When you consider fish consumption in India, it's around south contributes around 25%, and northeast you can see 60% of the population they consume fish. But when you go to north, it's around 7%. So in north and central India, the consumption of fish is comparatively very less. So as I was earlier it was all extensive systems, and when we went for intensification of aquaculture, where the production has, when the extensive systems, the production was around 5 kilograms per hectare. Now the production has gone to around 7 tons, 8 tons. People think of 10 tons per hectare. So you can just imagine the amount of, how much production has increased and how much intensification has happened in aquaculture. In an extensive system, even now in Kerala, the production is around 250 to, sorry. So even intensified, in Kerala, the extensive systems, we have around 250 kilograms per hectare. And now, think about intensive systems, it has grown the productivity has grown improved very drastically. And especially this particular species, which is shown, the Binami, its production alone is around 1 million tons. So you can just imagine the production of these when it comes to aquaculture. But one of the main problems when we intensified the aquaculture is the presence of infectious diseases, whether it's bacterial or virus. Because the shrimps are lower down the evolution, and because of that they don't have well-defined immune system, and because of that they are much more prone to infectious diseases compared to the vertebrates. And the infectious diseases are spread because even in India we started intensification, as I told you, in the 90s, and that is when the disease started. Before that, disease was very less, and now we have around 20 different viruses infecting shrimp alone. And the number of bacteria, you can just imagine, even things which we thought that it never infects shrimp has started infecting fish. When from our laboratory we have reported wherein a Vibrio cholera infecting O139 infecting shrimp, and that has been published. So we can see that across, earlier we used to think that the bacteria or viruses which infect human beings doesn't infect the aquaculture animals. But then now we can see that there is a lot of cross infections between this. So that is where there is a lot of chance of transmission of diseases. And one of the major issues is the poor water quality. That is where we always fail in terms of aquaculture, because when the production is very high, what happens is there is a lot of waste which is generated in terms of fecal matter and also the feed debris which falls in the pond, and that creates a poor water quality. And another thing is that unlike in veterinary practice or medical practice, even though there are quacks in both these practices, in aquaculture there is only quacks. 99% is only cats. So everybody is a doctor in aquaculture. So that is one of the major issues. And even they don't know what they prescribe, and even the farmers doesn't know what is being prescribed to them. And even we have done a study in probiotics where we have seen that what they sell as probiotic is actually antibiotic. It's not probiotic. So you can just imagine one of the probiotic. I think we did around 60 probiotics. We studied about 60 probiotics. We found that 2 of the probiotics didn't have any bacteria. So that's how we started just thinking why this doesn't have any bacteria. Then later on we identified 4 different antibiotics in those two probiotics. And when we think about the use of antimicrobial compounds, you can see China, now they're using around 6,000 tons of antibiotics in aquaculture systems. And it is going to rise to around, by 2030, it is going to be around 22,000. And India is much low. It's around 2,000, around 1,500 tons now, and it's not going to increase much. And one of the major issues is that 6 common classes of antibiotics which is being generally prescribed in human medicine are being used in aquaculture. So that is the biggest issue. So if you go to aquaculture ponds, if you ask the farmers, they will always say, no, we don't use any antibiotics. But then if you just go around the pond, and then just you see a lot of packets there, which is labeled antibiotics. And mainly because you don't require any prescription for all these antibiotics. I just visited Vimora once, and then we had a survey through the entire Andhra coast. We were just surveying the aquaculture probiotics in those areas. And then we saw one big, it's almost like a hypermarket. You go and pick up, you go with a bag and then you can pick up your probiotics. That big, the number of probiotics which is being registered in aquaculture, as aquaculture probiotics is around 1,500. So you can just imagine the number of probiotic brands which is available. And then there is no regulations as such. The government is trying to introduce regulations, but then I think it is mostly a self-regulation rather than a regulation in place. So one of the major issues when you use antibiotic in aquaculture is that drugs in fish feed persist in the aquatic environment for a long time. And fish do not effectively, they don't metabolize the antibiotics. and 70 to 80% of the antibiotics which is applied in aquaculture are dispersed in the water systems. So it doesn't go into the animal, it becomes part of the aquaculture or the aquatic systems. And the antimicrobial use in aquaculture is governed by a lot of factors. It can be poor governance wherein you don't have a regulatory framework, lack of knowledge on AMR, which is obviously there because when you go to the rural areas, nobody knows what AMR is. And then obviously climate change is there, wherein unseasonal rains are there, because when there is unseasonal rains, there is a lot of stress on the aquatic animals, and then diseases come very fast. Especially diseases like Aeromonas in freshwater fish or Vibriosis in brackish water shrimps or fishes is very common when there is drastic change in the temperatures, because the temperatures in the daytime will be around 35, 40, and suddenly when the rain falls it becomes 20. So that sudden drastic changes in temperatures can lead to multiplication of these organisms. And they are most of these pathogens in aquaculture, they are common cells. You take Advertella, you take Aeromonas, you take Vibrio, this is already present in the pond. But when there is stress on the animal, then these fly-ups are. And then, of course, antibiotic is readily available. You can just go and get from any counter. And when you go to these places, where aquaculture is done in large scale, you see in bags antibiotic being kept. So they just take those bags and dump into the aquaculture ponds. And antibiotics are marketed in different ways. There is no proper labeling also. And when you think about antimicrobial use in aquaculture, the developed countries, they have done away with most of the antibiotic usage. But when you see places like Chile, you can see that Scotland, Norway, it is only 0.39 per gram of biomass. But then when you see Chile, it is around 660 grams. So we don't have any data of India, that's why I am unable to present that. And then one of the major issues is metaphyletic use of antimicrobials, because you cannot take one fish and treat. It's not possible. It's possible in aquaculture, aquarium system, but not possible in aquaculture system where millions of animals may be there or lakhs of animals may be there. You will not be able to individually pick the fish and treat. So normally it is a metaphyletic treatment. You have to treat the entire populations. So that also contributes to the AMR. And aquaculture systems are considered as hotspots of AMR gains, and we have seen that in studies 90% of the bacteria in seawater is resistant to one or more antibiotics, and 20% of the bacteria are resistant to at least 5 antibiotics. And another thing is that there is a lot of cross resistance also. Some of the bacterial communities which are resistant to heavy metals can lead to antibiotic resistance also. Those which are resistant to metals, they are resistant to antibiotics also. That can cause resistance also. And fishes are reservoirs of zoonotic pathogens and bacteria of public health significance, because we do work on that, and we find that most of the pathogens, you name any bacterial pathogens, it is there in the fish also. So the different drivers of antimicrobial resistance are from aquaculture. It can go to the human health, local environment. So it's a cycle wherein it circulates between all these. From humans, it can be carried to the environment, from there to the aquaculture, so it's a cycle. So it can be anything, because the human waste is when it's dumped, or from the hospital waste is dumped to the aquatic system, and then there the fish is reared. So you cannot consider one as a single system. So it's all interlinked. And normally this is what happens when the fish is grown. Initially it is either in a closed system. It's in the first this part, and then the open system wherein you have an exchange of water. Then you have a closed system where you don't exchange the water. In either of these cases, what happens is once you harvest a fish, then the water is being dumped into the aquatic system, normally without any treatment. And if there is AMR bacteria in those ponds, then definitely, or if antibiotic is used on these ponds, and naturally it will be transferred to the aquatic systems also. So this is one work which has been done, it has been reported. This is based on different works which has been done in different parts of the world. So we have seen that the percentage of bacteria which is antibiotic resistant in aquaculture is around 33%. And in fisheries fisheries means the capture. I mean, you go and catch the fish. There it is around from 52% it has reduced to 22%. That means there is a drastic reduction. Because maybe probably because that there is a lot of hygienic practices which has been implemented of late, and because of that the presence of resistance genes has been less reported towards as of now. And this is one work which has come in Nature. Again, you can see that these are the antimicrobial resistant hotspots. You can see that the southern India is always there, and then you have the Vietnam, then you have China also. Probably we will not be worried about this because there are a lot of institutions which work in Kerala, especially in aquaculture. You have the Kerala University of Fisheries and Ocean Sciences, you have CMFRI, you have CAFT, you have Cochin University of Science and Technology. So a lot of papers are coming from these places on antimicrobial resistance because two things are there. One is it's easy to publish AMR work, so naturally people are tempted to work on AMR, and then of course sometimes we will be a little bit carried away because once we get AMR patterns from a particular area, then we tend to go, we become a little bit biased to go to that place and then NP. So doesn't mean that it's a hopeless situation, but then the thing is we have to be careful because the southern India is supposed to have a lot of AMR pathogens. And when you take the marine environments also, similar conditions there, you can see that the south of Kerala and also the Tamil Nadu, it has a lot of AMR pathogens. And this is about the antimicrobial resistance in foodborne pathogens isolated from aquatic animals. You can see that against ampicillin, some of the antibiotics is almost 100%. So that means there is a lot of AMR pathogens present in the aquatic foods or aquatic animals. And there is a lot of interlinkages which happens, and this can be, and these interlinkages causes underlying factors and AMUs, they contribute to the AMR. And it can be vulnerable to bacterial because some of the species are much more vulnerable, just like tilapia. Tilapia, earlier we thought that it is not vulnerable, but now there is a lot of diseases which is coming in tilapia. Then antimicrobial availability, disease diagnosis capacity. So a lot of things, factors which contribute to the antimicrobial use. So how we can control the use of antimicrobials in aquaculture systems or maybe fisheries is that one is the biosecurity measures. So anything which prevents the entry of pathogens to the farms or hatcheries, they will be helpful in controlling the AMUs. So it can be different strategies, people implement different strategies, and biosecurity is one of the major issues, major things which we can implement to prevent bacterial or disease as such. So even farmers are willing to implement these because if less number of pathogens means you have a better better returns. And aquaculture is an industry wherein in 100 days you are going to get your returns. When you take shrimps, the Vanami, once you put the shrimp into the pond, and when you harvest, it's only 105 days, 100 to 105 days. So in 100 days, you're going to get returns, and that's almost double, more than double. That's what the returns you're going to get. So it's a highly risky business. At the same time, it's highly remunerative business. So farmers are always willing to, put in a lot of biosecurity measures. Another thing is limiting the use of antimicrobials. So sadly in India, anybody can purchase an antibiotic without any prescription. So that is one thing which favors the use of antibiotics. And sometimes the farmers also doesn't know that they are actually putting antibiotics. When you take aquaculture as a whole, not in Kerala, but then you take Andhra Pradesh, you take Gujarat, you take Maharashtra, or Tamil Nadu, even for that matter, there are consultants in aquaculture farms. So what they do is, they are the people who act as doctors, and they prescribe these probiotics or antibiotics, whatever it is. But sometimes what happens is, they prescribe antibiotics in some other name, and the farmers, without knowing, they will be dumping these into the aquaculture systems. Another thing is the vaccines. But one of the major issues with vaccines is that, as I earlier told, they are lower down the evolution, and because of that, they don't have a well-defined immune system, especially in shrimps. But in fish, it is much more developed. But the thing is that many of the developed countries, they have vaccinations, but they are all for high value fishes. You cannot think of a vaccination in a species like carp, where the cost is only 100 rupees or 120 rupees per kg. So you can think if it is 500 rupees per kg. So that is one of the major issues when vaccines are concerned, and vaccines are not very popular in this part of the world. Then another thing is the certification. The major issue is that certification is limited to export products only. It's no way related to the domestic market. So whatever we sent across to export, because India is one of the biggest exporters for seafood, and we are exporting. We hope to export on seafood worth of 1 lakh crores. So that's what we aim to. Now it's on 6,000 crores. And most of the importing countries, they insist on certification. Certification means they require that AMs are not used, antimicrobials are not used in the systems. But sadly, for domestic market, it's not there. Then news media, definitely they can bring in a lot of changes in terms of use of antimicrobials. I'll just tell a little bit about probiotics, because that is one area which we are working. And this is the definition of probiotics. I'm not going to read this, but basically they are live organisms which is given to the fish or the shrimp, and they act in different ways. So there are 2 different types of probiotics which is being used. The second one is not really a probiotic, because probiotic is to be given to the animals, but in aquaculture systems normally we say water is added to the water also is a probiotic. So one is a gut probiotic which directly feeds the fish, and the other is added to the water to improve the water quality. And lot of mode of application, actions are being proposed. It can increase promotes reproduction, improve the water quality, or antiviral effects. So a lot of things, lot of mode of actions has been proposed for these agricultural products, and it has been proved. And probiotic use can lead to any of these: increased growth, increased survival, increased digestive efficiency. A lot of things being but one of the major issues in India is that we don't assure the quality of these probiotics, because there is no system in place, there is no regulation in place wherein we say that okay, these probiotics are safe to use. At the same time, when you take European Union, they have only just one probiotic which is being approved for aquaculture. So that means how much stringent, you can just imagine how much stringent they are with regard to giving regulatory approvals. So these are the common probiotic bacteria which is being used, and Bacillus is one of the favorites for aquaculture probiotics, because Bacillus are spore formers and then they can be stored for a long time. So that's a major advantage, because when you go to places like where summers are very severe in Andhra, where the temperatures can go up to 50 degrees centigrade, so only Bacillus can survive. So normally that is the probiotic bacteria which is being commonly used. And the market of probiotic is around $100 million, and it's growing substantially. So, and as I was telling, one of the major issues is this: there is no regulatory framework. So what you see in the background is a shop which is there in Machilipatnam, which we have visited. And there are other alternatives also to limit the control. Vibrios is one of the major issues there. So you can use phages for the control of Vibrios, because Vibrios has nowadays become a major issue for shrimps especially. And as I was telling, Vanami, the production itself is around 1 million tons, and then Vibrios is one of the major issues. And we have come out with a solution wherein phages can be used, viruses that can attack bacteria, and they can reduce the levels of these bacteria to a large extent, thereby controlling the infection. And these are some of the works which we do in our laboratory. One is the methods for rapid detection of pathogens and characterization of their pathogenic potential, that is mostly the human pathogens. We do work on the antimicrobial activity of nanomaterials, and we work on bacteriophages and probiotics, and also we test the different fishery products or oil-restricted products as per SPS requirement. Yeah, this is our lab, and thank you.
Thank you, Dr. Toms, for the wonderful presentation which you provided
the details regarding the impact of AMR in aquaculture. The topic is open for discussion.
What type of Vibrios you would like to use? Or Vibrios?
Vibrios, one of the major, it depends on at what growth stage it is. So if it is in the hatchery, where we have very small shrimps where it is grown, it will be around 20-day old. There normally it is Vibrio harvest. But when you go to the grow-out pond, when you go to aquaculture ponds, it can be Vibrio paraphyleticus, that's a major issue. Vibrio vulnificus is an issue, but as I said, we have even reported Vibrio cholera there. And it's a human pathogen, O139 has been reported. Which had. Yeah. Now, yeah, but others, they don't cause disease because they don't have virulent genes for which can cause disease in human beings. But these which we have reported, it has the cholera toxin also. So virtually this can act as carriers of human pathogens also. So that is the biggest issue which is going to happen.
Sir, are there any reports of AMR in marine fishes, sea fish that we consume?
See, the thing is that, even though AMR is being reported even in mummies, you say that it is there. So that means AMR is not a problem which has started off late. It has been there, it will be there also. Because why bacteria develop resistance to antibiotics is because there are a lot of bacteria which produces antibiotics in the environment itself. So naturally, they have to develop mechanisms by which they can survive, because it is always a survival of the fittest, and there can be horizontal transmission, there can be vertical transmission of these AMR genes. It's always possible. What we have seen is that 20% of the marine fishes. There are two reasons. One is it can be directly from the marine environment, but later on, the ice which we use, the handlers, it can get transmitted to the fish. So there are two ways it can come to the fish. It can be either from the marine environment, or it can be also. And you see, most of these, the sewage is being directly dumped into the marine environment. So you can seriously, actually I was working in Gujarat for a while, and when we took the Google map of that area, we can see the color difference. The areas near the town is a little bit black in the sea, because everything is being dumped. There are a lot of, Varal itself, the place I work, Varal itself is having around 100 seafood factories. So all this waste is directly dumped without any treatment. We are supposed to treat it, but then officially it is treated, but then unofficially it is being dumped. And you can clearly see the change in the color. So obviously it means that it is being done. And then that can all lead to this, because when there is eutrophication, and along with these waste, there's a lot of pathogens also can come, or even it can be AMR also. So basic thing is we don't treat our waste.
So is there any difference in the occurrence between cultured fishes and marine fishes? So is there any significant difference?
Yeah, cultured fishes and marine fishes, there is difference, because cultured fishes, what happens is the entire, as we were describing, the terrestrial animals, the humans, whatever the waste comes, whether it will be antibiotic residue or when the hospital waste, it directly comes to the aquatic environment. And normally all this aquaculture happens in the inland waters. And inland waters, they are nearer to the areas where human occupancy is there. And naturally, there it will be more compared to the marine environment.
India is a leading exporter of fishes. How we are able to maintain that certification when we have these much antibiotics in our aquatic environment?
Yeah, that's a good question. The thing is that, see, I'm sure that, sooner or later, a regulation will come wherein they say that A, B, C, D, AMR pathogens should not be there in our products. It's going to happen. Why I'm saying is that there is a lot of Indo-UK projects which is coming. I feel it is for all that, because they want the data to be generated, and they want a hold on the data, and which gets into the hand, because you can just see in the lot of projects which is coming up on AMR between the industrialized countries or the developed countries and India, and that shows that they are interested in the AMR profile of our country. That is one thing. What was it? Sorry.
Certification.
Yeah, certification. The thing is that a lot of our products are getting rejected because of the use of antibiotics.
But still, India is leading.
We are not the leaders. We are not the top. We export, but we are not the top.
But I wonder how our consignments are accepted by the.
See, the thing is that there is a system in place wherein if our consignment is found to have antibiotics, then every consignment is, now the thing is, you check hardly once in 3 months, once in 6 months. They keep a periodicity of that, and they randomly pick, and then they test it for the presence of antibiotic residues. But once they find that one consignment has antibiotic, then they check the entire consignments which is coming from India, and sometimes they ban also entry of our products. But of late, there is a lot of interventions by different government agencies, wherein this use of, earlier it was like, that's how probiotic market has developed in large scale. I'm not saying that probiotics, everything is bad. No, we found some probiotics to be bad, but then there are really good probiotics. Around 40 to 50% of the probiotics are really good. It's other 50% which is not, it's not good. So the government of India has really put in a lot of, thrust on the implementation of many of the regulations, and because of that, now the rejections are comparatively very less. Earlier there used to be a lot of rejections happening, and then we also have, maybe our infrastructure has also improved, wherein we can test any consignment for the presence of antibiotics. So earlier we rarely test any of these consignments because it requires sophisticated instrumentation. It requires LCMS, and we were having 1 or 2 LCMS maybe 10-15 years back, but now we have a lot of LCMS which can detect many of these. So it is for the farmer, for the government, and also for the factories, the seafood factories. It's very important that this should not be there, because once one is negative, one is positive, then it's going to affect the entire export. So government is taking a lot of efforts to see that. The thing is that once these products have antibiotics, then naturally it comes to the local market, because we don't have any regulations here. We have regulations, not that we don't have regulations, but then there's nobody to implement those regulations.
One of the problems is that we don't have any. We don't know how to use the antibiotic. We don't have any data how it has to be done, because one of the drugs that is also tetracycline, that need to be given once in 3 days in fishes, but whoever is practicing, they are giving it on every day, and the residue remains for almost 27 days in the fish. When you give one single dose of oxytetracycline, not 3 doses, for 27 days. Actually, what we are following in our place is the data that is coming from the European countries. Okay. But fish is a poikilothermic animal. There in Europe, the metabolism of fish is much faster because it's a temperate climate. Here it is a tropical climate. The metabolism is comparatively much slower. And we are following the practice of using the antibiotics as that is followed in the Europe, which actually add on the residual levels. So we definitely should have a specific protocol. That is, in veterinary practice also, we have to have the antibiotic used for every separate animals, because the pharmacokinetics is different.
I think there need to be a lot of research inputs which should be coming into that, because we don't generally work on that. But the funny thing is that antibiotic use in aquaculture is banned. It should not be used. We are not supposed to use. So, being that the case, again we have to think, we have to open up at least few antibiotics for use in aquaculture, and based on the studies which is being conducted, where we see that
Is permitting chlorphenicol and those antibiotics which are not used in human beings to be used in aquaculture. Chlorphenicol and such antibiotics are permitted in aquaculture.
no, it's not permitted because
In
we.
India,
No. Yeah, other countries it's permitted, not in India. India, everything is banned. And the rejection level for chlorphenicol, I mean for like exports in EU is around 0.1 ppb. So it's very minuscule.
Okay, thank you, Dr. Tom. We will proceed to the next session.
So thank you so much.
Thank you so much, sir. The next session will be handled by Dr. Divya S. Balachandran. Dr. Divya S. Balachandran is a qualified professional in Ayurvedic medicine with a BAMS and MD in Ayurveda, complemented by specialized diplomas in yoga and food safety and quality assurance. She currently serves as the Assistant Production Manager at Aushadhi Kuttangalur, Thrissur. She has previously held key roles in Research and Development Department and Quality Control Department. Dr. Balachandran's scholarly contributions include the publication of 7 papers in reputable journals and participation in over 20 presentations at both national and international seminars. Her involvement in diverse projects spans the gamut of production design, clinical studies, toxicological assessments, bioavailability studies, pharmacodynamic and pharmacokinetic studies, process troubleshooting, and quality assurance practices. Dr. Divya has also played a pivotal role in collaborative projects with esteemed institutions such as CFTRI, TBGRI, NIAST, and KFRI. She has been instrumental in protocol preparation and execution, actively monitoring research projects. We welcome Dr. Divya S. Balachandran to talk on the topic Scope of Ayurveda in Prevention and Management of Antimicrobial Resistance.
Thank you. First of all, thank you the organizers for inviting me for such a presenting in front of such an allied audience. I would convey first of all, because I am not an expert in this field, I would like to share some of my views wherein I think Ayurveda has a role to reduce the risk of surge of AMR. So here I am going to present the topic Scope of Ayurveda in the Prevention and Management of AMR. Rather than the management of AMR, I would be explaining the role of Ayurveda in the controlling of infectious diseases so that antibiotic usage will not be needed in such cases. So I am a part of Aushadhi. Aushadhi, you may be knowing, is the largest producer of Ayurvedic medicines in government sector in India. And our motto is to supply quality medicines at affordable prices to the common public. So I would rush because Eva ma'am already told me that it's time for lunch. So antibiotics, as we know, are the life-saving measures. But why it is so much to be used nowadays? Because we are in a very fast world now. So earlier we had a very good practice of diet and exercise, a balanced regime throughout the day and throughout the seasons. That has completely changed. Because of that, we are having a reduced immunity and there is a very high surge of infectious diseases. We are now in the post-COVID era. So we are all aware of that. And next is misuse. Next is the misuse of antibiotics, wherein the AMR picture is coming to occurrence. And these are the areas where I think Ayurveda has a role to play. Because we always give a antibiotic anticipating the risk of secondary infection, and in the area of veterinary and agriculture also a lot of antibiotics are being used, and there are also other sources where antibiotics are coming into human body. They are the contamination by pharmaceutical waste and subtherapeutic exposure through NSQD drugs, banned antibiotics, or use of antibiotics as preservatives even. In these areas, I don't think Ayurveda has a role, so I won't be explaining that. So what is the Ayurvedic approach for healthy living. That in Ayurveda, the interventions of Ayurveda can be divided into two. For Swastha, that is for a healthy being, and for Adura, a person with a disease, that is a patient. For Swastha in Ayurveda is defined as a person wherein all the elements of the body are in equal proportion and his digestive fire is in a healthy state. Here I would say the term digestive fire throughout this presentation. By that I would mean, in Ayurveda, it means that the digestive process, the digestive method that is taking place from the mouth to the excretory process. The whole thing is termed as digestive fire. So the normalcy of the digestive fire indicates the normalcy of whole digestive process. And also normal excretion of the waste from the body, and also the healthy state of soul, sense organs and manas. That is also very important as far as a healthy being is concerned. And in the modern terms also, definition aims at the social, spiritual and mental well-being of the individual and not merely the absence of diseases. So the regimens of Swastha, that is, if a person is to be in a healthy state, to maintain in that healthy state, Ayurveda has advocated a lot of regimens. Daily regimens, we say it as Dinacharya. When should we get up? What is to be done after that? Even the medicines or herbs which is to be used for brushing is mentioned in Ayurveda. Cleaning the tongue, everything is mentioned in Ayurveda, but we cannot follow those strictly in this world now. And next is Ridhucharya. Ridhucharya means our body will be responding differently in different seasons. We know during the summer season we have to take a lot of water. During the rainy season, that is the time when the digestive fire is very weak. So we will be having a lot of infections at that time. So each season, a special Ridhucharya is being advocated so that the person remains healthy throughout the year. Next is coming to Adura, that is a patient. How can we treat a patient? As you all may be knowing, Ayurveda is having a holistic approach. Whereas in modern medicine, I am not blaming any system. Every system is having its own benefit. So, holistic approach means we are treating the patient as a whole and the disease as a whole. Apart from that, when we take the modern scenario, if we have a fever, the temperature is high, we give an antipyretic. Okay. Whereas in Ayurveda, we search for the cause. Why this temperature is high now, and in spite of prescribing mere antipyretics, we go for the root cause correction so that the body itself corrects the temperature of the body. So that is the holistic approach. I will explain some examples wherein Ayurveda has played a very important role in controlling infections. First of all, we had the COVID scenario where Ayurveda was hand in hand with allopathic treatment to control the spread and also for the treatment of the diseases. Here also it was criteria was divided into two: Swastha wherein the people was in quarantine, and Adura, the COVID positive patients. In Swastha, the line of management was immunomodulatory drugs so that they won't get positive. And then digestive support. Digestive fire is very, very important. I will explain it later. And then diet and lifestyle modifications so that their digestive fire is in the proper state. Next, coming to the COVID positive patient, the treatment was determined as per the severity of the symptoms. And even without antibiotics, we could manage mild to moderate severity COVID patients. I think most of the patients were taking antibiotics by themselves, fearing the secondary infections after the COVID onset. So that is also a reason for AMR, right? So then post-treatment rejuvenation and restoration. Our body will always be weak after a strong infection, and also after a strong medication. So prophylactic sort of treatment was also given so that their restoration to the normal health was easy. Then also diet and lifestyle suggestions was also given. Here this paper was published in Frontiers, Ayurvedic Response to COVID-19 Pandemic in Kerala and its impact on quarantined individuals, a community case study. This was a project headed by Ayush Secretary Sharmila Madam and Collector Divya Iyer, and it was coordinated by Dr. Raj Mohan. He is a faculty of Government Ayurveda College, Trivandrum. Here they found out that a lot of projects by different names like Amritam, Sughaishyam was implemented in the government sector as a whole for the Swastha and also the Adura. There they have concluded the study by saying that such projects can be effectively handled, and also while checking the percentage of quarantined patients who developed who became COVID positive, when we take the people who had Ayurvedic medicines, it was 5 times lesser than the people who did not have, who didn't opt for Ayurvedic preventive measures. Okay, the percentage was 0.34 in the case of Ayurvedic interventions, and without Ayurvedic interventions it was 1.64. Okay, such drastic changes were noted, and this Ayush 64 tablet was gaining very much importance that day. CCRIs had developed this medicine for malaria. That is actually an anti-malarial drug, but it was very effectively used against COVID-19 patients in mild and moderate severity cases. So in this case also no antibiotics were used. I will explain 2 cases wherein I think Ayurveda has a role. It is to be thought of Ayurvedic interventions has a role where antibiotics is not working. In most these 2 cases, we regularly prescribe antibiotic, or the patient goes and buys antibiotics, but it is not necessary that antibiotics should be given. The role of Ayurveda in antimicrobial resistant pharyngitis, actually antimicrobial resistant, they have not assessed antimicrobial, whether it is antimicrobial resistant or not by microbial methods, but the patient was not recovering from his symptoms even after continuous use of antibiotics. So he opted for Ayurveda. So this is the case, 29-year-old male patient present with complaints of recurrent sore throat, foreign body sensation, alteration of voice, recurrent episode 3 to 4 times per year in the last 2 years, no relief after taking antibiotics and NSAIDs. Patient was assessed using tonsillopharyngitis assessment scale and also visual analog scale, and pain intensity was also measured. Then Ayurvedic herbal formulations was given twice a day for 3 days. Then Shodhana therapy we say for eliminating the deranged elements from the body. It may be inducing vomiting or inducing purgation, bloodletting like that. In this case, they had induced vomiting. Even after 3 days, the symptoms got much relief. After that, they went for Shodhana therapy. The administration of Ayurvedic treatment ameliorated the presenting symptoms without any reports of side effects. The interventional medicines exhibited antipyretic, anti-inflammatory and analgesic effect. By correcting the tonsillitis itself, the symptoms were also relieved. Next case is where we always opt for an antibiotic, post-surgical prophylaxis. Even after the extraction of a tooth, we definitely take an antibiotic. Why I don't know, because we don't trust our body, I think. Body has an inherent capacity to cope against infections. So it is not necessary that in every case of infection we need to give antibiotic. We should support our body to cope that infection by itself. This is only a suggestion. The role of Ayurveda management in preventing surgical site infections instead of surgical antibiotic prophylaxis. The patient was 83-year-old male presenting with acute urinary retention because of PPH. Holmium laser enucleation of prostate was done, and he was not given any antibiotic during the prophylaxis period. Ayurvedic medicine only was given. This Ayurvedic medicine was started 3 days prior to the operation, surgical procedure, and it was continued for 2 weeks post-operatively in doses and combinations. His recovery was remarkable and he returned to his daily routine in very short time without any complications. And the total observation period was 6 months. I think this is a very important area wherein Ayurvedic interventions can be considered. So, coming to the prevention of AMR, how can we prevent AMR? That reduce intake of antimicrobial agents. That is the first and foremost thing. That can be done by strengthening the host or source reduction or reduce the transmission. Now coming to the strengthening of host is a major area where Ayurveda has a role. Because in Ayurveda we say Roga Sarve Abhi Mande Atno. That is the derangement of the digestive fire is the root cause of every diseases. So normal digestive fire imparts strength and immunity to the body, and every treatment in Ayurveda starts with the digestive care, that is Deepana and Pajana we say, to improve the quantity and quality of the digestive fire, so that even the medicines is being properly absorbed and it has a therapeutic activity. Most of the medicines is having ingredients which is having a digestive support action, and also digestive support is given in the prophylactic period so that the body returns to the normal state easily, and also there is very less disease recurrence. So this is the importance of Agni, that is digestive fire in Ayurveda. Here we can just check on the gut microflora. Gut health is the key to good health. So these are the wide variety of symptoms that occur because of the dysbiosis of gut microflora. Actually, we all are aware that at least one dose of antibiotic within 5 to 10 days will flush out almost about 60 to 70% of the microbiota from the body, and it will take around 2 to 3 months for the body to regain this microflora inside the gut. Each individual is having a specific gut microflora. So even if we are supplementing this with an external agent, say probiotic or something like that, it takes a lot of time to get into the normal state of that individual. Only after that, the body will develop immunity or a capacity to fight against diseases. See, gut-brain axis, these are the symptoms or disease conditions which occur due to the dysbiosis of gut microflora. It is affecting the gut-brain axis, gut-brain endocrine axis, gut-heart axis, gut-lung axis, gut-liver axis, gut-pancreas axis, gut-bone, see, it is the different variety of axes wherein this flushing out of microbiota is being affected. So by giving a single antibiotic, we are inducing another set of diseases into the human body. In Ayurveda we say treatment is pure. Shuddha Chikitsa means a treatment which cures a disease and that will not produce another disease. So is this a pure treatment? That is a thing to be discussed, I think. So we go for the supplements. So prebiotics and probiotics. Prebiotics are the food for the bacteria and probiotics are the live bacteria. Even if we supplement with these, it is very difficult for our body to get into the normal state. Now it is an era of supplements. We take calcium pills, but we will not take buttermilk or milk or anything. We will not take sesame. We will not take those things. We will go for calcium supplements, and we will go for protein supplements rather than taking lentils or pulses. It is like that. But have we heard of anyone having a heart attack because he ate so much of lentils or pulses? But is these supplements necessarily taking us to a healthy living or a happy body? That is also to be discussed. Everything is being supplemented from outside rather than making the body to to produce or to absorb it from the food we are taking. Just see, gut microbiome is also having action in producing substances that transport vitamins, minerals and other nutrients. So after giving antibiotic, this is also being deranged. So next is the prevention of AMR by source reduction. It is a matter of discussion wherein Ayurveda can be, Ayurvedic interventions can be made in agriculture on a large scale. By, I think Agricultural University was having a project wherein Aushadhi used to give the waste materials after the extraction of kashaya and all, and they used to treat the soil with these waste herbs. Even if it is waste after the extraction, it is having a lot of phytoconstituents. Rather than chemical fertilizers, it is very effective if it is treated, if this, the soil is treated with this herbs and all. So they were distributing this as manures, and they were saying that it is much effective, almost equal to the chemical fertilizers. So that is an area where I think Ayurveda has can intervene, because a lot of pharmaceutical companies are there and tons of waste are being disposed everywhere. So I think that can be considered. Next is veterinary medicine. Veterinary medicine is also developing nowadays. Mruga Ayurveda, we say, Hastya Ayurveda and Ashwa Ayurveda are all branches of that. And now Aushadhi is supplying Chavanaprasha to elephants at Guruvayur temple for their rejuvenation and all. So that area can also be considered, so that at least we can contribute something to reduce the use of antibiotics. To reduce the transmission. That is mainly by management of infections. As you all may be knowing that Ayurveda has an immense potential in managing infections, and if we search for the antimicrobial property of herbs, n number of results may be coming, but nobody is taking it to another side. Just we are prescribing the medicines. I think it is because research is lacking in that field, because the combination, if we take a combination, it will be having an n number of phytoconstituents, and it is very difficult to go for the pharmacokinetics or pharmacotherapeutics of all these phytoconstituents. So maybe that some evidence base is lacking somewhere. Maybe because of that it is not coming to the front screen. Next is digestive support, that I had already explained. And in Ayurveda, there are groups of medicines or herbs mentioned which has specific action against specific infections. Like there are 10 drugs which is having action against urinary tract infection, like that. That also can be considered instead of antibiotics. Then after the treatment, after managing these diseases or after correcting this root cause, symptomatic relief is automatically attained by the patient, and Ayurvedic interventions strengthens body to cope the infection by boosting inherent mechanisms. Next is as a prophylactic treatment after the intake of antimicrobial agents. There, by Ayurvedic interventions, we can repair what has been damaged. Already the body will be recovering from a major disease and also recovering from high dose of medications. There Ayurvedic supplements can be given. Also reintroduce beneficial bacteria through Ayurvedic measures, and also rejuvenation, that is formation of new cells and all. That also lot of herbs are having many antioxidant properties and all. There also Ayurveda has a role. So this is I think very old question, whether modern or Ayurveda. Both these sciences having their own good and their own bad. But I think as far as AMR is concerned, the first and foremost thing we should do is reduce the use of antibiotics. There, Ayurveda is less prone to developing AMR because of these reasons. There are several mechanisms wherein bacteria or microbes develop this AMR. First of all, bacteria cannot easily develop a resistance to plant materials due to complex and multiple chemicals that are introduced by the plant materials, and therefore multiple azotes. Even one herb is given, it is having a lot of phytoconstituents. So bacteria cannot synthesize its own antimicrobial resistant agents against all these phytochemicals. So that is one area where Ayurveda has an upper hand. Then next is mechanism of AMR by bacteria by producing efflux pumps. Efflux pumps means they are removing the toxins from their cells so that they can grow and develop. Including the antimicrobials, this efflux pump mechanism is being developed, which contribute to AMR. So some plant materials has the natural capacity to inhibit efflux pumps and therefore known as antimicrobial resistant modifying agents. And berberine, we say Daru Haridra, Cocinium fenestratum or Berberis fenestrata is very successful natural ingredient that has been used as an efflux pump inhibitor so that the same antibiotic can be reintroduced into the human for killing the bacterial cells. Next is QS. Quorum sensitization is a method by which the bacteria respond to cell population density. It is a measure of their virulence. And now instead of antibiotics, there is a QS model. And most of the chemicals used in the QS model are the natural ingredients. So in that area also herbs has an upper hand. Then plant-derived materials role in inhibiting biofilm formation is another mechanism by which AMR is developed, and mainly phytoconstituents derived from tea, epigallocatechin gallate. It is proven to have this biofilm inhibiting activity against Listeria monocytogenes and many other SOS pump. All those of the bacteria is inhibited by this phytoconstituent from tea. Using plant compounds against production of toxins by bacteria, that is antitoxins, that is also a developing area to use instead of antibiotics. Those antitoxins will not kill the bacteria, they will inhibit the bacteria from producing the toxins. Agel marmalose, that is kuvalam. The unripe fruits of kuvalam is known to produce antitoxins against cholera species. Surprisingly, in Ayurveda, we have a disease named Vishujiga. Vishujiga means the major symptom is diarrhea itself, can be correlated to cholera. There, the main drug used is kuvalam only. And in case of kuvalam, it is specifically mentioned that unripe fruits are to be used. All fruits should be taken ripe except that of kuvalam. So, I don't know, this is having no scientific basis, but when we read these both together, it makes some sense. So, this is the take-home message. Ayurvedic treatment can be used as a tool against AMR, and the key to reduce AMR is by prevention. Prevention, that is definitely by improving our immunity, reduce the use of antibiotics by Ayurvedic interventions, and also monitoring the antibiotic exposure from other sources. And I would, as an Ayurvedic physician, I would definitely recommend to go back to nature, rather Ayurvedic lifestyle for a healthy living. Thank you.
Thank you, Dr. Divya. Dr. Divya has given a narration on how to remain swastha and how to deal with the Adura and how to prevent the AMR. Any questions regarding all these things?
Ma'am, what about the quality control of the finished products of the Ayurvedic medicine?
That is a major area of concern because I told you all these phytoconstituents are there. So it is very difficult to develop a standard for each product. each product will be having the most number of, I think 44 ingredients are there in Mahamanjishrati Kashaya. It is very difficult to develop a standard, and even after if we develop a standard, it is very difficult to get that standard in each batch, because each drug will be having variations depending on the seasons or the place from where it is procured and all. But we are having stringent quality control measures, including the heavy metal content also, and also it is being strictly followed in Aushadhi, at least I can say.
I have a question that you gave details of 2 cases.
Yeah, yes.
One is of pharyngitis, recurrent pharyngitis with amoxiclav and azithromycin, and there was no relief, but there is no proof whether it was a bacterial.
No, I told you earlier, the microbiology study was not done.
And the second case, prostate removal, patient had no prophylactic. No, in our modern medicine, we are not prescribing prophylactic antibiotic for clean surgeries.
Okay.
Okay, thank you, Dr. Divya. We will proceed to the next one. One more topic is there for presentation.
Thank you, Dr. Divya, for that very interesting session. Let us move on to the final talk in today's technical session by Dr. Ashokan KG, Assistant Forest Veterinary Officer. Dr. Ashokan KG is an accomplished professional who holds a degree in BDSc and AH, postgraduate certificate in veterinary homeopathy and CPST. With a diverse service history, Dr. Ashokan has served in the AHP Kerala as a veterinary surgeon practicing alternative systems of medicine, especially homeo and Unani medicines. Since 2010, he has managed his own wards implementing alternative medicine practices. Presently, he serves as an assistant forest veterinary officer in Thrissur, Kerala, aiming to produce antibiotic residue-free milk and meat in various districts. Dr. Ashokan has successfully applied alternative medicine to more than 1,000 animals owned by 180 farmers, earning appreciation for his significant contributions in this field. We invite Dr. Ashokan KG to manage the session regarding the subject Alternative Systems of Medicine to Address Antimicrobial Resistance.
I am very thankful to talk this much gathering. It's the first time. I am here introducing some field experience, not a scientific way. Here I am using homeo medicines and the Unani medicines from the last few years. Here, small size particles can absorb more easily than heavy particles. So we use nanoparticles of homeopathic medicine. So it enhances absorption levels with less time. Here I am showing one medicine with the one bottle. 1 ml is enough per day, as well as that powder mixture which can mix with 5 liters of water, then giving 50 ml per day only. What is the mechanism of action of this medicine? I don't know. I am giving one chance to study, and you should enlighten these material actions of medicines to the animals. Here, why these farmers? Because of the protozoal diseases as well as mastitis and infertility problem. Almost all farmers are fed up how it should proceed to farming area. The farming area, entire farming area is a standstill condition, and the population of the cows are nil nowadays. But our practice area, giving these medicines, we are encouraging the farmers to come forward for better farming area. Here we are providing homeopathy medicine, likewise Unani medicine. Moreover, as in the previous presentation as talked, clean water and clean fodder is the main source for rearing cows. Here through the One Health we can protect our animals, mastitis. Here we are in homeopathy medicine and Unani medicine, more than 12 types of mastitis are recognized, and giving lot of antibiotics to different types. In more than 5 or 10 types of antibiotics are applied to the cows. Here we are applying only as medicine only as shown in the previous time. We are giving only health, providing only healthy medicines, not any antibiotic. Here mastitis is prevented, the action of medicine is not known, but the mastitis is prevented. We have to find out how it works. Likewise, why infertility is managed. Likewise, protozoal disease. Here we are providing healthy, good health only with nutrients. Without extra feed, milk production has increased. I am showing this farmer. Last 6 years I am giving only one medicine for this farm. Here 6 animals have died with protozoal disease, diarrhea and anaplasma. Now last 6 years we are using only this medicine, only homeo medicine. Then farmers get adopted. Another thing is the number of house flies has marked reduction and approaching to 0. We are giving this medicine to the animals. Even single house flies cannot be occur, since the reactive peoples and veterinary public health peoples are visited this farm, and that is why I am here. I am not interested to talk and come in front of this much gathering. I don't like. This is the first time I am coming with. These people are the only reason why I am here. Here also some goat farmer also. She is engaging in rearing goats. More than 100 goats are here. She is rearing these goats with antibiotic previously. Nowadays only homeo medicine. Now their kids mortality reduced, increased body weight of goats, free from ectoparasite. These are the main features I have noticed. How will get the antibiotic free certification? That is another way I am facing, and as previously somebody presented topic. How farmers under this alternative system of medicine inquiring about it, since they are using the alternative system of medicine from years back. What is the procedure and the method to adapt it to get antibiotic free certification? That is the main question we are facing. How we will get the antibiotic free certificate? Today morning itself I am facing, I am hearing some words that my cousin got heart failure today morning. That time I am admitted my cousin to the medical college. The doctor suggested not given single tea, coffee and even milk to the cousin. Then only water, pure water. Then I am asking why you are preferring not giving tea or coffee. Milk is not good. Like So last 6 years I am using this medicine without giving any antibiotic to these animals. We are producing milk. Then what is the method to get such a antibiotic-free certification to this product? That is another way I am here. I am not here. I am not arguing that this is the only medicine which can cure all the diseases, but it can be a medicine or system of medicine that can cure some problems. Here I am using this packet, one bottle medicine for 100 days. It's cost effective, only 3 rupees per day. It's cost. Here no other supplementations are given, only grape powder and plenty of water. So you can ask so many questions, but now I am not prepared to answer it, since I am not against the modern medicine, but this is the one method I adopted to encourage the farmers. So next time, yesterday I heard so many questions from a lot of my friends, especially Dr. Pradeep Kumar. He are asking 14 questions to me. Why you are going to present this talks to this national seminar? Well, then only I replied him that I am giving a single clue to this our scientific persons. Then they can experimentally can prove why this happened, what is the action of these medicines to the animals, and how it does work. Likewise, so I am not arguing this is the only medicine that can cure all the diseases. Only healthy animals can produce hygienic milk and meat. Recommended to give plenty of water to the animals. This one photo I am showing here is it is in Karnataka and Tamil Nadu. This medicine is plentifully used in goshalas. So many goshalas are using my medicine. They are preventing houseflies from this. Their goshalas. For goshala, they are using my medicine last 3 years. in goshalas, no flies. Why flies are going back means I don't know, but it is happening. That is. Here, protozoal diseases are not transmitted because of the cutaneous larval migration is prevented by destroying these flies. So in Karnataka, this is seen. I have seen this scene. That is one boy is sucking the milk of this. How the medicine works and what are the after effects of the medicine, that can be find out by scientific means. For this, I will do cooperate with us with you, and you can visit also the forms at any time. I think the blood and urine samples can analysis can find out the action of medicine. I believe it so. Through the repeated visit of these farmers, cattle shed, everybody can realize the fact. But I have no more scientific information regarding this alternative system of medicines. Through the One Health approach, we can together protect our livestock. Thank you. This is the only.
Thank you, sir, for sharing your experience on your homeopathic medicine as a way to prevent AMR. The topic is open for discussion.
I think this is the lunch time, everybody is a kind of, so I am very thankful to God.
Sir,
Thank you.
so medicine procured from the homeo doctor?
No. I am procure medicine from the directly here, one agency, Hindustan Homeo.
Yeah.
They will supply surplus quantity of medicine to us. I purchase, this medicine contains only 12 medicines only 12 medicines. I require 1 ml, only 12 ml of medicine mixed with 100 ml of water. Then giving 1 ml. Here happening is that health of the animals become very good.
So it's a combination of 12 different medicines into one bottle.
Different medicines.
Okay, mixed into one
Mixed
bottle.
with water.
Okay. So for 1 day for one animal, 3 rupees.
3 rupees. That is.
And that one bottle for one animal.
1 bottle for 1 animal they can use. No, nothing. It's giving into the animals, they will prevent all these things. Infertility management is mastitis is not broken and flies is not there. Moreover, in reactive people visited that time they are surprised because in farm no smell and other things. That time onwards I am visited our meeting with Dr. Sunil sir. Please give how we can find out antibiotic free things here. Lot of in Kozhikode now one group of farmers, three farmers there, more than 400 animals they are rearing. They are collecting milk to new international market. They are exporting this milk to Gulf countries. One Suguna group of rearing chicken, they are also using my medicine. They are rearing 1,50,000 birds. Anyway, I am not publishing my medicine to anybody, but I am keeping it. So for scientific way, you have to prove it, and please help me to explore this branch of medicine. I will with you. Thank you for patient hearing. Once again, thank you, Lord.
Thank you, sir.
Thank you, sir. We have now come to the end of technical session of the National Workshop on Preventing Antimicrobial Resistance together. The organizing committee extends their sincere gratitude to all the dignitaries for such an informative and enlightening session. The organizers would like to hand over a memento to all the speakers of today's technical session. I now invite Dr. Thrissur, the chairman of technical session, to receive our token of appreciation, and Dr. B. Sunil, head of the Department of Veterinary Public Health, to hand over the memento. I invite Dr. Sushila KD, co-chair of today's technical session, to receive the memento from Dr. B. Sunil. I invite Dr. Ampili R, rapporteur for today's technical session, to receive the memento from Dr. B. Sunil. I now invite Mr. Thomas Matthew, coordinator Asia Pacific, to hand over the memento to the speakers. I invite Dr. Deepthi Vijay to receive a token of appreciation. I invite Dr. Chitra Valsan to receive our token of appreciation. I request Dr. Thrissur PD, Professor and Head of Department of Veterinary Epidemiology and Preventive Medicine, to hand over the memento to the speakers. I invite Dr. Divya S. Balachandran to receive our token of appreciation. I invite Mr. T.K. Prakash to receive our token of appreciation. I invite Dr. Ashokan KG to receive our token of appreciation. We once again thank all the dignitaries. I request all the dignitaries to assemble for a photograph. I humbly request all the dignitaries to assemble for a photograph.
Thank you everyone from inside Kerala. Please come.
All the dignitaries, please come forward for the photo session.
Asif, come. Come.
So Dr. Rajni signing off.
Thank you so much.